Myself, Dr. Anil Sharma, Senior Consultant working at Apollo Hospital, Delhi, and I welcome you all on behalf of the Anesthetic Society. Wish you the best of academics and best of relations which you will carry forward from here. Many of us are like connected like families from 2014 onwards. COVID has told us this thing that what is important is the relations, and that's what luckily the 20 or the 25 odd which with whom we are connected from 2014 onwards, most of them suffered from COVID, and it was a very strong association with each other, helping each other, helping each other's families. You have to see to believe it, and I can tell you that once you leave this hall on Sunday, you will see that how many members you have added to these families. I can assure you that. So with this, I welcome the opening batsman, and it's Dr. Devesh Arora, please. Yeah, let's start the academics. Thank you.
May I invite Kavita Sandhu madam to please chair the session.
मैम को
So good morning once again. So before we roll off, just want to make a few comments. So I think the opening batsman is the brain, and that is where it all begins. So well chosen. Secondly, just want to share with you all that I was so happy to see that a large number of the speakers in today's neuroanesthesiology subsession have worked with me, and my heart swells with pride to see their successful journey so far. May God take them. So I call it a maternal pride or whatever, but you know, the higher they go, I feel better and happier, and may God take them to higher and higher heights. And going forward, I just want to make one comment about the topics. They have been chosen with a lot of care. I went through them, beautifully cherry-picked, and I'm sure that you all will go back enriched in more ways than one. So without wasting any more time, we go on to our first speaker, and that is Dr. Arora. May we have his introduction, please? Your first slide.
Yeah. Thank you, ma'am.
So Dr. Devesh Arora is Director and Head Anesthesia and OT Services at Asian Hospital, Faridabad, and he's going to tell us a little more about how he tackles this very difficult issue of awake craniotomy. So over to Dr. Arora, please.
Thank you, ma'am. Good morning, ladies and gentlemen. I am thrilled to be an opening batsman or speaker for this prestigious conference, TASCON-2022. At the outset, I'd like to thank members of the organizing team for giving me this opportunity to be a part of this prestigious event. I bring greetings from Asian Hospital, a 425-bedded super specialty and multi-specialty hospital situated at Faridabad, where I've been working since last 12 years in various capacities, and today I am the head of the department. We run an academic program wherein we have DNB from 2017, and of late we started Academy of Regional Anesthesia Fellowship for 1 year under the aegis of EURA. So I would like to begin my talk by a disclaimer. I do not practice neuroanesthesia exclusively. My practice is limited to neuroanesthesia. We do around 30 cases of neurosurgical procedures in our hospital, out of which 60% are spine and rest 40% are cranium. So what I'm going to share is my experience about how I do the awake craniotomy. Some of the images I have taken from Google. As I always say, Google Baba ki jai ho. and references are going to be from PubMed, and I'm assure you that I'm going to stick to time so that we can have time for discussions. So this is going to be my lecture outline. I'll introduce the concept of awake craniotomy, discuss few cases which I did in my hospital, the technique for the awake craniotomy, and then I'll do a quick review of literature, clearing off the doubts which I would have had if I had been sitting in this audience, and then I would like to summarize. So what is awake craniotomy, my dear friends? It's most commonly used to map the resection of brain tumors which are located near the eloquent cortex. By eloquent cortex, I mean those areas of the brain which govern the speech, the motor area, as well as the sensory areas. Sometimes it's done for epilepsy surgeries, and in some institutions in Western countries, it's done for supratentorial tumors, whereby reducing the length of stay, reducing ICU admissions, as well as avoiding the risk of general anesthesia. So let me present you my first case, which I did very recently in the month of April. A 54-year-old male gentleman posted for a left parietal lesion, and the complaint was seizures. So what is most important is a good preoperative workup, and I will not go into the investigations, which were all within normal limits, and echocardiography was also done. But what is most important is to establish a good rapport with the patient pre-op. Although the surgeon had already explained what the patient is going to go through for next 3 hours during the surgery, but it was my duty as well as to establish a good rapport. I went to his room personally and explained the entire procedure to him as well as to the relatives. So once on the day of surgery, the patient was shifted to the pre-hold area. We checked vitals, NPO status, consents, antibiotic status, and anti-epileptic drugs, whether they were given or not. And we re-explained the procedure once again as to what we are going to do in the next 3 to 4 hours. So this is the intraoperative care phase, a little congested slide, pardon me for that. We applied monitors, and then we gave injection fentanyl 60 micrograms and midazolam 1 milligram. This was given to get some kind of a procedural analgesia as well as sedation, because I was going to give a scalp block. After the scalp block was given, I'll describe the technique in subsequent slides. We initiated dexmedetomidine at 30 micrograms per hour. His weight was 64 kgs. We applied a DVT pump, bear hugger, and since the surgery was about to last around 4 hours or so Foley's catheter was inserted. We gave supplemental oxygen, and in subsequent slides we will show you how did I do it. And then after 15 minutes, after checking for adequate analgesia, we applied the Mayfield skull clamp. IV paracetamol and diclofenac was given to take care of the pains, other pains which patient might perceive while lying down supine, and ondansetron was also given. So in next few slides, I'll take you through the scalp block and how I did it. Essentially, scalp block is blockage of 6 nerves on either side. Majority of them are branches of trigeminal nerve, supraorbital and supratrochlear, branches of frontal nerve, ophthalmic division, zygomaticotemporal, auricotemporal, as well as lesser occipital and greater occipital. So the cocktail which I prepared, I took a bowl, and in that I took injection ropivacaine 0.75% 20 mLs, then added adrenaline 200 micrograms, then added dexamethasone 8 milligrams, then magnesium sulfate 500 milligrams, added NS to make the total volume of 40 mLs, and final concentration which resulted was injection ropivacaine 0.375% with adrenaline 5 micrograms per ml. So this is how we did the supraorbital supratrochlear nerve. A green sterile sheet was placed under the head, and a strict asepsis was followed during all these procedures, and recording was done. Okay, now I'll explain the procedure of supraorbital and supratrochlear. So you palpate for the supraorbital ridge, locate the foramen, and then hit the foramen medial to it, and 2 mLs is injected, 1 ml initially, and then 1 ml in the medial direction to take care of the supratrochlear nerve. It's very easy block to give. It can be given with ultrasound guidance also, but placing a probe with a good length footprint is little difficult. So this is how we did the supraorbital as well as supratrochlear nerve block. Next comes the zygomaticotemporal nerve block. We give it at the lateral angle of the eye. The nerve runs under the temporalis fascia, as well as some branches are above the temporalis fascia. So we hit the bone first, inject 2 mLs, and then while withdrawing, inject 2 mLs above the temporalis fascia. So as you can see, I am hitting the bone, just confirming, aspirating, then injecting 2 ml of the drug. Then while withdrawing, another 2 ml is injected to take care of some of the branches which might lie above the temporalis fascia. So auriculotemporal nerve block, we look for tragus, look for the superficial temporal artery pulsations, try to palpate, try to go behind the superficial temporal artery and gave around 2 ml of the drug, local anesthetic cocktail which I had prepared. So as you can look for yourself, I am trying to feel for the pulsations of the superficial temporal artery. This can be done with the help of a USG probe also. Once I have hit the bone, aspirate and then give 2 ml of the local anesthetic cocktail which I had prepared previously. What about greater occipital nerve block? We draw a line between occipital protuberance and mastoid process. Medial 1/3 and lateral 2/3 junction. Greater occipital nerve is located medial to occipital artery. So it can be done with the help of ultrasound guidance or without that. In my case, I did with the help of ultrasound guidance and used a linear probe and did a outer plane approach. Hit the bone. So I'm redirecting slightly to be on the better side of the medial to occipital artery. Aspirating and then injecting 3 ml of the local anesthetic cocktail which I had prepared previously. What about lesser occipital nerve block? It's located on the same line but at a slightly lateral to the greater occipital, medial 2/3 and lateral 1/3 junction. Again we give 3 ml of local anesthetic in this position. So we have blocked 6 nerves on the left side and the same procedure is repeated on the right side. So how do we take care of the patient intraoperatively as far as monitoring is concerned? Standard monitoring, ECG, NIBP. Initially we take NIBP 5 minutes, but subsequently we made it 10 minutes so as to not to cause a little pain to the patient, because inflating and deflating can be a little troublesome for the patient who is lying up for around 3 hours in the supine position. And I'll show you how we monitored end-tidal CO2 in a spontaneously breathing patient. So supplemental oxygen can be given with the help of a oxy mask or nasal prongs. In our case, we use specialized nasal prongs from intersurgical company, which is known by Sentry ETCO2. The beauty of this nasal prong is that one of the prongs is used to aspirate the gases and it takes towards the CO2 monitor, as you can see from here, and we can get a good CO2 graph. If you want to use a mask, you can use the same Sentry mask from Intersurgical, which has got a separate port to measure the CO2. So this video on the left hand side of the screen is showing you the entire setup, how we actually did it. And we can see for yourself the monitoring. We are getting a good CO2 trace. This is all possible because of this special kind of a nasal cannula. Now, how we actually did the resection phase in which we started the monitoring. On the video on the right side will show you how we actually did it. Volume नहीं आ सकता इसमें? इधर लगेगा इस तरह से.
Shiva, volume.
Can I have the volume, please? Yeah. Anyhow, the volume is there. We are asking the patient to protrude the tongue, talk to us, asking his name. And then to the end, I think it should be there.
जीप दिखाना बाबा. ठीक है.
नाम रोहित शर्मा.
transfer his name, where he resides, so as to see whether his speech is functioning properly or not. And since we were operating on the left side motor cortex, we were regularly checking the
बाबा
right
सीधा वाला पैर हिलाओ,
toe
चलाओ,
movements.
शाबाश, ठीक है.
So as you can see for yourself, we have placed a L-shaped screen, okay, so as to have a continuous visualization of the face of the patient, as well as in case we have to rescue the patient with the help of general anesthesia, we can use a video laryngoscope or a eye gel to intubate the patient. So this is another patient we did in November 2021, a 43-year-old male gentleman posted for right frontal parasagittal lesion. So similar way we did it, and again we used the intersurgical century cannula. Another patient we did in 2018, 32-year-old male patient posted for tumor of right motor cortex, again done in a similar fashion. So this is again in a video where we are checking the grip of the patient, various movements, because it was involving the right motor cortex. So as you can see, the patient's head is turned towards the left side, and we are asking the patient to perform various motor activities which we are asking. So what are the intraoperative challenges which we can face as anesthetists while taking care of this patient? So one is claustrophobia. So as I explained, we placed a L-shaped screen so as to keep the face visible to us all the time. Tongue fall can happen. We can have a decrease in the oxygen levels where we have already given a supplemental oxygen. And hypertension, if it happens, we can take care with the help of esmolol. If seizures happen, we have to have a cold normal saline available in our OT. The surgeon can sprinkle 20-30 ml on the focus where he is actually doing the surgery. This helps. A lot of literature is available. This actually helps. And in the meanwhile, you can give 1 or 2 milligrams of midazolam and be prepared to convert to general anesthesia if it's required. I'll take 3-4 minutes more. And emergency conversion to general anesthesia, we can use a video laryngoscope, and a stellate tube or a eye gel can help us. So I'll do a quick review of literature as to what are the questions, if I had been sitting in this audience, I would have for my speaker. So without wasting much time, are there any contraindications for awake craniotomy? Yes, my dear friends, only the patient refusal can be one of the contraindications, or patient has got a kind of a dementia or large vascular lesions. Otherwise, overall, if you are able to establish a good rapport with the patient, you will be successful. Is awake craniotomy the gold standard for tumors of eloquent cortex? Overall, the literature is little mixed. It will appear intuitive to us that it should be the gold standard, but as far as the meta-analysis of 17 observational studies which I have cited here, the authors found they could resect the tumor more, but it was not statistically significant. But overall, the survival period as well as neurological deficits were quite similar in both groups. So as of now, I cannot say it is the gold standard. So what is the choice of anesthesia technique? What I have described to you is a all-awake technique with moderate sedation. There is another technique which is available in the literature, which is known as AAA technique. That is, the patient is asleep. Then during the resection phase, we waken up the patient, and then the patient goes again to sleep or can be awake. So why do we need general anesthesia from the first instance? For the patient positioning and the skull pinning and craniotomy and dural opening. And there is a meta-analysis published in PLOS 2016. Overall, the results are similar in both techniques. So choice will depend from institution to institution. So is scalp lock the only solution? As a beginner, you might feel a little jittery that if I have not done scalp locks, how can I give a scalp lock? You can do with a field block. The results are almost similar. As per this evidence which I am quoting, there is no difference in efficacy, but it's an easy block to give. And I'll share with you good YouTube resources where you can follow them and you can give it for yourself. So is there a role of any adjuvants? In my initial LA cocktail slide, I showed you that I used dexamethasone and magnesium sulfate. This was from this reference where they have shown if you add both of them, then the quality of analgesia, requirement of intraoperative dexmed goes down. What are the plasma concentrations of local anesthetics? Since we are using a large volume, we are using the upper limit of a volume, but there might be a fear in our mind that we might exceed the toxicity thresholds and might lead to seizures. Extensive research has been done in this subject as early as 2004 and then very recently in 2022, where they have found that the levels of ropivacaine were under the threshold limit. So you are safe to use up till 3 milligrams of kg body weight. So can we use ultrasound? Definitely. I'm a big fan of ultrasound. In my career, I've used only ultrasound. This is one block which I use both ultrasound as well as landmark based. The reason being the footprint is little big. If I have a hockey shaped probe, then I can definitely use that. The advantages cited in this narrative review are you can cut down the volume as well as you can find aberrant anatomy. There are certain vessels located which we might miss with the landmark based technique. So another question which came to my mind is, like, while reviewing the literature, can we preoperatively predict that this patient is going to have a turbulence during the awake craniotomy phase? Yes, my dear friends, there is a Karnofsky's performance status scale. As you can go through, the scale less than 70 can be a troublesome for the patient. So I am almost reached to my tail end of the presentation. The success of the awake craniotomy is always dependent on right patient selection, and then you have to have the right multidisciplinary approach where we need a skilled anesthesia team, experienced surgical, as well as a good cooperation from nursing as well as OT technical sites. So I am an occasional neuroanesthetist. So these are a couple of the references. In case you find time, please go through them. Anesthesia for awake craniotomy, how to guide for an occasional practitioner, and a good article from Awake up to date. In case you are finding any difficulty, please contact me. I'll be more than happy to share these articles with you. And what about YouTube resources? There are excellent YouTube resources. One of them by Dr. Hetal Vadera. The video is there. Initially when I started doing in 2017, I watched his video, and there is a good video by Dr. Kalaeswaran also. You type scalp block and YouTube and you will get good resources. And another resource which I find very useful is from Duke University by Dr. Jeff Katzen. Right now I'm not connected to internet, otherwise these resources would have already started to play. So that's all for my side, my dear friends. Thank you for patient listening. And most of you have already clapped for me. In case you forget to do so, thank you. Thank you very much.
Do we have time for a couple of questions? Okay, so are there any questions from the audience?
What we do is block fails and patient starts complaining of pain in the intraoperative period.
Okay, so the upper limit of the ropivacaine is 3 milligrams per kg body weight. So I mixed the solution, prepared around 40 ml. So I used 14 ml on each side, that is 28 ml. So I was still left with 12 ml. So I would have requested the surgeon to infiltrate at the site. So that works pretty well. You can use xylocaine with adrenaline also. And we have not exceeded the toxic limits, so I think that works pretty well.
I think another very interesting aspect was that cocktail that you used. Maybe that is worth a thought. We ourselves aren't using a cocktail, so I'm sure there are others in the audience who also have their gray cells ticking.
So my practice is like always use dexamethasone for peripheral nerve blocks, but I know there would be criticism from the audience also, because Dr. Hetal is looking at me. IV dexamethasone versus perineural dexamethasone, there's a lot of debate going.
Yes.
But I am one proponent in favor of perineural dexamethasone, because although it might not be statistically significant, but in my practice it turns out to be clinical significant. If you get analgesia for more than 2 to 3 hours, it might not be statistically significant as per studies, but I am happy that I have prolonged the duration of analgesia for peripheral nerve blocks by 2 hours. Yes, ma'am. KPS score, ma'am, I was not aware. In fact, for preparation of this lecture, I started the reviewing of literature. I came through this score. It is actually related to the daily activities of the living. Score above 70 means the patient is able to perform daily activities of living on his own, is well oriented, is able to understand what we are trying to say. Less than 70 is slight dependency. I cannot recollect the score, but 70 is the cutoff mark, and it has been extensively reviewed in literature. I was not aware. The benefit of whenever I get a lecture for these conferences is it increases my knowledge. So this score I came to know. I mean, I think there are a lot of neuro anesthetists sitting here, and they can throw more light. I'm an occasional practitioner. That was the biggest disclaimer I gave in the initial slides.
Any more questions?
Yeah, Dr. Devesh, everyone is interested in your last slide. From where did you get it?
Actually, it is long time back. Even I do not recollect. 6-7 years back, I got from some of the presentation in Google, and I saved it, and I've been continuously using, and I get admiration for this slide in all my presentations.
Thank you for being honest.
Devesh sir, one question.
There's
Sir,
a question.
how do you keep these patients calm throughout the surgeries? Sometimes these patients become agitated. They are not comfortable. They keep on asking how much time you are going to take. So how do you keep them calm?
What we did was we started, as soon as we finished with the scalp lock, we started with dexmedetomidine at 30 micrograms per hour. That worked well for us in my setup. And when they were like resecting the tumor, I decreased to 20 microgram per hour. So that, as you can see, he's responding pretty well. He answered all our questions. All the patients answered all our questions. So that works well for us. Whereas in the literature, in the Western countries, they use a TCI of propofol and remifentanil. I think we do not have, I do not have a TCI pump, so.
Thank you, sir.
Any more questions? So I think we can move on to the next talk. Thank you so
very much,
Dr.
ma'am. Thank you.
Varan.
Thank you.
Also, I appreciate your sharing your resources. I think that's very useful, the last bit that he shared, the resources, because YouTube is an ocean. You can dive in and hunt forever. So thank you so much for that.
Thank you, ma'am.
If you have any other questions, you can always ask on our Facebook group. That is the advantage of this conference.
So we move on to our next topic, and that is posterior fossa surgery. To share his thoughts on this today is here with us Dr. Keshav Goyal. I think Dr. Keshav doesn't need much introduction. We have all heard him on numerous occasions, but for those who are new here, he is the additional professor of Neuro Anaesthesiology at All India Institute of Medical Sciences here in New Delhi. And he's going to share his thoughts on posterior fossa surgery, another big bugbear in neuroanesthesiology.
A very good morning all. It is indeed a pleasure to be part of this TASCON society. The introduction which I got, I was thinking I should be a part of it now, very soon. So my topic is posterior fossa neurosurgeries. Now, before almost few years back, this surgery was thought to be inoperable. Why so? This is the largest and deepest cranial fossa in the brain, which comprises with the densely packed with the vital structures like brainstem, pons, midbrain, medulla. Cerebellum is there, and also the cranial nerves from 3 to 12 and all the major sinuses of the brain. Sigmoid sinus, transverse sinus and the occipital sinus are there, which are compactly fixed in that rigid and tight compartment. So it does not have a compliance. If anything, like the fluid, hematoma or the tumor comes in, that will lead to the compromise of these structures. At the same time, you can see here, basically the CSF pathway is also very narrow here. The third and fourth ventricle is being connected by a cerebral aqueduct of Sylvius, which is very narrow. So if something comes in, that will lead to the compression of this and lead to the obstructive hydrocephalus. Patient will be ultimately obtunded, will have raised ICP. So what are the most common pathological lesions in this? They are the tumors. Coming to the children, almost of all the tumors, the brain tumors, almost 2/3 lie in this area of the brain, that is posterior fossa. There are the vascular traumatic hematomas are also there that can be treated here. So these are the few images. You can see it's the CP angle tumor. This is the tumor in the cerebellum itself, the large tumor in the brainstem glioma. So these are the difficult anatomically located situation where the surgeon wants a specific exposure so that he can operate in this tight compartment. At the same time, it is equally and more challenging to the anesthetist. The clinical features will depend on what part of the brain is involved. If it is raised ICP, the patient will be obtunded, reticular activating system may be involved. If it is cranial nerve, the patient can have ocular palsy, and there can be involvement of the lower cranial nerves, which might lead to impairment of the cuff and gag reflex. So the patient might aspirate. So these patients are candidate for long-term tracheostomy and post-operative ventilation. Cardiac and respiratory vital centers are here. So the patient can present with arrhythmias, respiratory irregularities. And the cerebellum is also here. So the ataxia and gait symptoms, gait abnormalities may be the presenting symptoms of these patients. So what are the special anesthetic considerations which we need to take care while doing this? Unusual surgical position. They are done in almost any, you name the position, they are done. They can be done in the supine, prone, lateral, they can be done in the sitting position as well. And the modification of that, because they will have more complications, and these complications need to be like deadly venous air embolism can be the one of the complications of sitting position. Potential brain stem injury. While taking out the tumor, you can take out the normal brain as well. Lengthy surgical procedures, of course they are time consuming, and neuro monitoring is required to see the integrity of the brain, the whether it is condensed. So you have to modify your anesthetic plan. So how do we go about it? How to do it? So after thorough history taking and systemic evaluation of the pre-existing neurological condition and cardiorespiratory status, we evaluate for the cerebellar and cranial nerve dysfunction, raised ICP presence, and we also see for the hydration status that needs optimization. Basic but very important, because these patients are bedridden, they are vomiting, and at the same time they might be given diuretics for their decrease in the ICP. So that needs to be taken care of before taking these patients. Preoperative documentation of any dysphagia, cuff and gag reflex impairment, that has to be done. You have to be explained preoperatively need for post-operative ventilation or tracheostomy if required in these patients, and extended ICU stay should be told to these patients. Previous operations, if this patient has been shunted, which is very common, so there is more chances of pneumocephalus, the air entrainment can be there. Coming to the investigations, apart from normal investigation, we go for, if we are contemplating this patient to be taken into the sitting position, then transthoracic echocardiography to rule out the PFO, which has an incidence of almost 5 to 35%, the normal population. So that will increase the chances of venous air embolism and as well as the pulmonary, paradoxical air embolism. Apart from routine monitoring, I will highlight more on this capnography. The ETCO2 will tell you about the venous air embolism in a quantitative and a very sensitive manner. So this is very important. The sudden and sustained fall of 2 mmHg of ETCO2 will lead that you are dealing with a patient of venous air embolism at that time in your OT. IVP, we have to place that. Optimal hemodynamics need to be maintained. The intervention that IVP has to be placed at the level of the external auditory meters, that is at the base of the brain, that differential location. If you are making a patient sitting, the artery should be at the level of the external auditory meters and the CVP should be at the level of the heart. So this is very important. Now specific monitoring like precordial Doppler, T and ETC, nitrogen oxide, that can be done to rule out and to find out the venous air embolism, and also the neurophysiological monitoring. CVP catheter, very useful to tell you what the volume status as well as therapeutic. In case of patients, those who have VA, we can aspirate the air intraoperatively. And there has to be multiple orifice catheter, that is very preferred. Generally, we use in a sitting position the subclavian vein, not the IJV. Reason being, when you are flexing the patient to the maximum, there can be airway, this venous obstruction can be there. That can lead to airway obstruction and you will not be able to aspirate the air. So we at our center use the subclavian vein. Coming to the various electrophysiological monitoring, neurophysiological monitoring to see the integrity of the cerebral function, EEG can be done. The evoked potential BERA, that is the brain auditory evoked potential, the wave 5 is seen. There is a decrease in the latency, increase in the latency by 10% and decrease in the amplitude by 50%. That means you are dealing with a brainstem compromise. The electromyography, that is the cranial nerve monitoring of fact, the 8th nerve can be done and the 7th nerve, which is very commonly done, and that is to rule out that you are not damaged these nerves while resecting the tumor. SSAP also can be done while you are flexing the neck in the sitting position. There is chances there is a stretch of the cord and that might lead to excessive neck flexion and quadriplegia of these patients. So that SSAP should be done for those patients. Positioning, as I have already discussed, it can be done in any position depending on the surgeon and the cardiorespiratory status of the patient, whether he can tolerate it or not. So choose the most appropriate surgical position that provide best surgical exposure as well as minimum position related risk to the patient. That is very important. The patient safety is very important. Sitting position has to be done gradually, taking care of the blood pressure, hemodynamics, that you are not causing cerebral hypotension. Precautions are taken. So here you can see the large bite blocks are not used. That will cause the airway edema because of the neck flexion. There should be abdominal gap between the chin and the chest. Avoid excessive flexion of the knees because there will be peripheral nerve injury. The peroneal nerve injury can occur. Legs in the thigh high position because that will lead to the venous pooling. That will avoid the venous pooling. And at the same time, padding of the bony points has to be done. And you have to take care of all the lines and ET tube properly. So it has to be done carefully, meticulously in a programmed and a protocolized manner. These are the contraindications. If the patent ventricular atrial shunt is there, that is a absolute contraindication. Right to left heart shunt is an absolute contraindication to a sitting position. Others are presence of PFO, extreme surfaces, and severe autonomic neuropathy. These are the few patients which are being done in our center. You can see the patient is being done. The T is also used. You can see here the transesophageal echocardiography. The arteries at the level of the external auditory meters, and the manometer for CBP is somewhere here. So these are the basic differences we need to. This is the child which is being done in the sitting position in the center. So these are the few of the complications which I've told you to: venous air embolism, quadriplegia, pneumocephalus. And patient can have venous air embolism. All these are the complications with this. So you have to be ready for deal with these. There are advantages also of sitting position. There will be less blood loss. The surgeon will have better access to the area which you want to operate. So these are the positive things. Now there are few modifications also from the sitting position, because sitting position you are having the sinus pressure is very reduced. So lounge chair position can be done, wherein you can increase the sinus pressure and the chances of venous air embolism can be reduced. But here you are compromising with the surgical access again. It can be done in the supine position, can be even done in the prone position and in the lateral position. Modification of the lateral and prone position is the park bench position. What we are doing here, we are just rotating the head 30 degree so that the patient is looking down and we are flexing the neck. So with that, almost all the qualities of the sitting position are met, and it is made a little early. So in case of posterior fossa hematoma, which has to be evacuated emergently, this position can be done. Coming to the anesthetic considerations, we have to facilitate the surgical access, that is important. Maintain CPP, the primary thing. We have to maintain the airway and the respiratory and cardiovascular stability throughout. Enable neuromonitoring, so that should not be hampered. You have to maintain the level of the anesthesia throughout well. And early detection and management of complications. Pre-medication, generally we avoid pre-medication, but it can be individualized. In a very anxious patient, it can be given in a supervised manner. Induction of anesthesia with the goals of normotension, normocarbia and normoxia. We pre-oxygenate, we give fentanyl followed by thiopenton. We generally use rocuronium 1 milligram, and we use lignocaine to avoid the raised ICP. And we use armored ET tube because we are doing neck flexion. So in between the patient, the tube can be kimmed. So we are using armored ET tube and controlled ventilation. Generally we use TBI in our setup because we are using neuromonitoring. So that's why we use fentanyl 1 to 2 microgram per kg per minute, per kg per hour, and propofol 50 to 100 microgram per kg per minute is given to these patients. Respiratory management, again the reinforced ETT, gap of at least 2 fingers between the chin and any bony point. That is very important, and you should always keep on checking the airway pressures. Going to the nitrous oxide, there is always a controversy whether it should be used or not, because it is notorious to cause more size of the pneumocephalus and the VA. In our setup, we are not using nitrous oxide, but there are studies, there is a school of thought that it can be used safely and there is no issue. So it can be still debatable topic. Presence of PEEP, whether we should use or not, because it is proposed that PEEP will lead to less VA. PEEP we are not using, reason being it depends on the chest compliance of the patient. If the lung compliance is not good, we have to use PEEP because the oxygenation is a paramount, and if lung compliance is okay, we are not using PEEP at all. Spontaneous ventilation, while we are resecting the tumor. So it was used to monitor the structural and functional integrity of the vital brainstem centers in few of the centers, but as we are using neuromonitoring, we are no more using the spontaneous ventilation nowadays in our center. Intraoperative cardiac responses. These are due to the surgical stimulation intraoperatively of the vital brain structures of the 5th nerve, 9th or 10th nerve, and while especially they are working in the floor of the 4th ventricle. So they can have bradycardia, tachycardia, ventricular ectopics, all sort of arrhythmias. So what you have to do, you have to tell to the surgeon. So generally if those stimulus are removed, these arrhythmias are generally gone. If it is not life-threatening, you should avoid using drugs that would mask these sentinel cardiovascular responses, and you will not be knowing what is happening while they are operating in the tight compartment. Coming to the emergence, the goals are pretty simple. It should be rapid awakening, minimize coughing and straining. Whether we can extubate these patients will depend on the preoperative status of the patient. What was it? Intraoperatively, whether there has been any brainstem handling, whether there has been any hemodynamic changes, or VAE or PAE are there. So that will decide whether we want to extubate or not. If we do not want to extubate, ensure adequate ventilation. There are two important things in these patients. The analgesia has to be optimal, because while suboccipital craniotomy, there is a lot of muscle retraction is there. So you have to optimally use the analgesia. Post-operative nausea vomiting, very important, because you are working near the vomiting center. So they are more prone for the vomiting and nausea. So that has to be taken care with the antiemetics, that is ondansetron and this. So to conclude, adequate pre-op preparation of the setup has to be done with the whole of the team. The surgeon, even the patient, nursing staff and the anesthetist. It should be dry run, team huddle, everything, what we want and what is possible. So that has to be, there has to be a well-balanced thing. Sitting position is a safe alternative to prone and lateral, can be done. Slow incremental position is done in the sitting. A strict perioperative protocol is needed to detect and treat complications. You have to be ready with for the complication and to treat them. Thank you.
Thank you, Dr. Keshav, for making such a difficult topic appear so simple. I think it is one of the surgeries where preparation is all important, and every stage of the anesthesia can throw up trouble, and where it is one of those places at the end of surgery also you can't relax. In fact, that is the most difficult part of the whole story. So thank you so much about that, and also thank you very much for sticking to time. Now with this little input from the organizers, they have requested that we keep the questions to the end, so I think we'll just move on. We'll save this 1 minute and give it to you when everybody's done with their talk. Thank you so much, Dr. Keshav.
Thank you very much.
So we move on next to ultrasound. And I think that has been the flavor of this season for quite some time now. Everybody has a probe in their hand and is trying to ultrasound everything that comes their way. Unfortunately, in neuro anesthesia, we don't have so much luxury, but yes, we are not far behind. And I think optic nerve sheet diameter is something that has caught the fancy of everybody, become very popular. We have Dr. Sumit Kalra here with us today to tell us whether it is really going to stand the test of time, it is really useful or not, and whether we should really adopt it in a more wholehearted fashion. Dr. Sumit is a consultant in Sir Gangaram Hospital, and he has been another dear colleague of mine who's moved on to greener pastures and probably increased his repertoire beyond neuroanesthesiology. So over to Dr. Sumit.
Am I audible? Yeah. Thank you, ma'am, for the kind introduction. Thank you so much. At the outset, I would like to thank the organizing team, TAS, Dr. Anil, Dr. Vinny, Dr. Hetal, for giving me this opportunity. I'm really glad to be a part of this family since its inception. I bring greetings from Sir Gangaram Hospital, and my topic for today is optic nerve sheet diameter, basics and applications. I'll basically walk you through how the thing evolved and how we can do it still, and what is the future currently. So of all the modalities of non-invasive assessment of ICP, ultrasonographic assessment has had a good correlation with ICP in many studies. This has been proven in many studies. There is a definitive advantage of portability of equipment. It can be rapidly performed, has a short learning curve and comes at a relatively low cost compared to the CT and the MRI evaluation, as well as avoidance of the ionizing radiation and the avoidance of patient transport for imaging. The basic anatomy, the optic nerve is surrounded by a leptomeningeal sheath, and within which is contained the subarachnoid space, which has the CSF. The intraorbital subarachnoid is in direct contact with the brain, and the entire part of the optic nerve is loosely attached to the dural sheath and is only surrounded by orbital fat. Here you can see in the image there is a direct connection between the optic nerve and the CSF flow. The maximum sheath distension, it occurs at 3 mm behind the papilla. It is shown in the image here. This is where we actually measure it. We'll come to the details of it. And it basically appears as a narrow rim. Whenever there's a rise in ICP, the CSF is pushed towards this narrow rim and the subarachnoid space in that area expands. From this look, it will come like this, and this is what we can pick up on the ultrasound. The subarachnoid space of the human optic nerve is actually not a homogeneous empty chamber. It is filled with CSF, and if you can see the image below, this is the image of the electron microscope, and it shows a complex trabeculae and septa system in the subarachnoid space. And the ONSD in the same patient may vary from different locations all along this sheet. This is a picture of the cut section, and you can see the variation in the subarachnoid space. The basics of ultrasonography is very important to know. One should be very well versed, and we are fortunate to work in a department where we have a very, very good top-line machine, and we do have a hockey stick probe and a linear probe. Basically, we have to use high-frequency probes which have low penetration, and we can use nerves or small parts preset, and some machines do come with the ocular preset too. And the ALARA principle of ultrasonic instrumentation should be used. There are two terms which are very important. They are often ignored because they are not stressed, but safety is of prime concern when we do ultrasound, and primum non nocere, first do no harm, is the theme of all our practice. So mechanical index is basically the relative potential of the ultrasound to create a non-thermal bioeffect, which is a cavitation or bubble formation, and the ideal value should be less than 0.23, whereas the thermal index is the indicator of a relative potential for tissue temperature rise. The aim is to first customize the settings to achieve the mechanical index of less than 0.23 and the thermal index of 0. We can see the settings on the top right corner of the machine. You can see it here. And the ergonomics is of prime importance when we do this, and the operator, the scanning area, and the machine should be in one line of vision. The patient should be supine with the examiner at the head end of the table. There should be no physical pressure on the globe per se, and there should be minimal adequate lighting in the room or ICU to get a good image. The picture depicts here one of my very dear senior, and we had this patient in the night emergency. Patient had come with an intraventricular hemorrhage and an external ventricular drain was inserted. We were able to do a scan, and you can see this that he has both the options with him, the hockey stick and the linear probe, and he could achieve a reasonably good image. And we made a video of also this. We'll just come to the video later. Tegaderm and jelly are very important and very, very easily available in the OT and should be used. The tegaderm is used to protect the eye. Secondly, one thing should be kept in mind that there should be no air bubble when you put tegaderm, because that will hamper your image acquisition. And copious amount of jelly can be used to enhance the image. Various views have been defined in the various articles, but commonly used views are the transverse and the sagittal view. Even the inferior view is used in some patients, and these are the images depicting. We can use both the hockey stick as well as the linear probe for the image acquisition. The scan, all the parameters such as the time gain compensation, depth and gain are individually adapted in order to achieve the best image quality. The globe appears homogeneously anechoic. You can see the image here. This is the globe, this is the lens and the anterior chamber, and this is the optic nerve, which is seen as a well-defined longitudinal compact structure, and the best results ask the patient to look forward with closed eyes. The sonoanatomy for the PGs, to just break it down, hyperechoic means white, hypoechoic means black. So basically you will see a black-white combination, and this black-white, we have just broken it down to how it looks like, that the optic nerve fiber is hypoechoic, it's black, the pi matter is white, the CSF is again water, which appears blackish, so hypoechoic, and the dura mater is again white. So the ONSD is measured as the space within the dura mater on opposite sides of the sheath. The measurements, it is typically measured 3 mm behind the vitreoretinal junction or the optic disc in each of the eye, perpendicular to the optic nerve axis. Using an electronic caliper, one should be well versed with this basic function of the machine, and the mean of the 3 measured values in 2 or 3 views is computed in order to reduce the inter-observer variability. Vigilant training is advised, and experienced sonologist needs about 10 examinations and novice about 25. So there has been a matter of debate about what has been the optimal cutoff value for ONSD, and the range of cutoff value is 4.9 to 6.2. And the likely cause is anatomical variation or measurement explanations, as in various studies use different measurement protocols to evaluate the ONSD. So that can be the cause of having variant results, as well as variability in the pathological conditions. Somebody has a mild disease, somebody has a severe disease. So you cannot label both the diseases in the same measurements. And the mean value in the recent concluded study among patients diagnosed with raised ICP was 5.82 millimeters. Trend of the ICP rather than absolute value is of more importance, and in the same patient over time, than having this attraction of finding the best fixed value. There are other measurements which can be done, the optic nerve sheath diameter and the eyeball transverse diameter ratio. This is of very much keen interest nowadays, and the optic nerve sheath diameter including and excluding the dura, the retinal artery Doppler, the difference between the ONSD and the optic nerve diameter. The ONSD ETD ratio is technically a more reliable indicator as per recent studies, and the normal value is about 0.18, and raised ICP the value goes up to 0.25. This is the video I was talking about, and we could see, first of all, if you could just, mouse is working. This is how the papilledema looks like. The papilla is elevated at the optic disc. Basically, we need to measure the optic nerve at the midline. So to confirm the midline, we can confirm the optic disc elevation in the patients. And this is how it will look like. You can always add a Doppler. Just scanning here, you can appreciate the papilledema. And then when we add Doppler, you can appreciate the retinal artery also. There are certain limitations of this optic nerve sheath diameter. There is a lack of uniform cutoff value. It is operator dependent. It has a potential risk of pressure injury to the globe. Has a false positive in certain ocular pathologies like leukemic infiltration, Graves' disease, optic nerve sheath meningiomas, and the acoustic shadowing artifact from lamina cribrosa or the optic disc. It has a definitive learning curve to achieve a good image without causing much harm and pressure injury to the globe. And the best view is still controversial, and it does not give a yes and no like POCUS or EFAST. And a degree of uncertainty is inevitable with the measurements at millimeter levels. Coming to the applications in neuro, predominantly it has been found to be useful for cases of cerebral hemorrhage, where it has been reported to have a diagnostic accuracy of about 100% in detection of ICP compared to Doppler indices. In subarachnoid hemorrhage, there is an increase in optic nerve sheath diameter with a persistence of expansion of ONSD even after the ICP has become normal, postulating an impaired retraction capability of the optic nerve sheath after a massive ICP exposure. In stroke, it is used in the casualty emergency department as well as in the ICU to monitor any complications in the early diagnosis of complications, as well as the effectiveness of the thrombolytic therapies effectiveness. For idiopathic intracranial hypertension, it is used both for diagnosis as well as monitoring. For hydrocephalus, it is used as a measure of surgical outcome, can be used for evaluation of shunt malfunction, selection of patients with idiopathic normal pressure hydrocephalus for shunt intervention depending upon dynamic variability. Now this post-LP headache, it has a role in diagnosis where the main finding was a significant decrease of ONSD while changing from supine to upright position. Even the response to treatment with the epidural blood patch can be seen by an increase in ONSD. In the ICU, this has a potential role in the early weaning from the invasive ICP monitoring, as well as it has a role in the pediatric ICU. And it can also be used to predict neurological outcomes in post-cardiac arrest patients. In patients with ALF, a higher ONSD was associated with a higher hospital mortality, and ONSD measurement is a feasible and safe and may have prognostic value. In optic neuritis, we can have one-sided significant optic nerve thickening as shown in this image. This is the image for the affected eye, and this is the image of the normal eye. We can appreciate a significant, or it can be used for diagnosis of the ailment also. In severe preeclampsia, we could definitely see a higher ONSD in patients who had got effect of cerebral edema. Other applications are posterior reversible encephalopathy syndrome. The transorbital sonography may be useful, and in meningitis and in encephalitis and the various infections, the role is still debatable. It has been found to be a very useful intraoperatively surrogate monitor for ICP measurement, and it is used in laparoscopic and robotic surgery where CO2 pneumoperitoneum and often a concomitant steep head-down position is used, and it is used to monitor ICP in patients with prone position and during procedures which require neck extension. Recently conducted TONS trial for percutaneous tracheostomy. I think it was conducted at AIIMS, and they found that the ICP got raised to detrimental levels during the procedure. In the post-op period, there have been very, very few studies, and but some studies have reported a decrease in the ONSD is associated with the post-op of cognitive decline, as well as there is a correlation between optic nerve sheath diameter and extracorporeal life support time. These are still the gray zones. The further research is happening here. Coming to out of the hospital applications, there have been research and studies on scuba diving, where the effect of scuba diving on the optic nerve sheath diameter was evaluated, and the scuba divers were evaluated to find a very high ONSD value. Similarly, in acute mountain sickness, there have been studies, and these are the out of the hospital applications, where this was a cohort study which was done, which corroborated that yes, the rise in altitude definitely affects optic nerve sheath. Then this was actually followed by a systematic review which showed that single point in assessment cannot be taken as the answer, so we need more evaluation. So they did a meta-regression analysis, and they found that there are certain limitations, but definitely currently the role is debatable, and the measurement might appear to be a promising tool, but the pathophysiology still is under investigation, and the portability is under investigation. The portability of ultrasound has sparked interest because of this, and now the studies have been further corroborated. This is the most latest study where they're evaluating the efficacy of portable machines to use to detect optic nerve sheath diameter at different locations. So they found the portable machines to be equally useful as the bigger machines, even better sometimes. And they have taken these portable machines to the helicopter as well as to the ambulance, and they have done studies, and they have shown that the transport via the helicopter causes a rise in ICP, and similarly the ambulance braking causes a rise in ICP. So both can be managed by just elevating the head end of the patient. Future perspectives, AI-based algorithms are being evaluated, and this was a study in which they compared the ONSD assessment by the clinicians versus an AI-based algorithm, and they found the AI-based algorithm gave almost the same precision results as the physicians. The road ahead, so what is the future? Where do we go from here? There have been articles around that, and the summary is that we need further more studies to achieve some standards of image acquisition, of technique, and points to grade the quality of image, and to compare the ONSD based treatment with standard treatment to determine if ONSD ultrasound results in an improvement with meaningful clinical outcomes or not. And the future research should also focus on defining the threshold and the behavior of the ONSD with increasing ICP, especially in some pathologies such as SAH and TBI. Before I conclude, this is a screenshot of the search results of PubMed of optic nerve sheath diameter. You can appreciate there has been a spark in the increase in publications in the last decade in optic nerve sheath diameter. So I would like to say that the invasive ICP monitor was introduced as a research tool in 1951. It took almost 4 decades for it to gain acceptance and got incorporated into the Brain Trauma Foundation guidelines in 1995. So ONSD has currently enormous potential, and with the growing interest in the ONSD research, it is presumably on the same path as the invasive ICP monitor. As for all the monitoring devices, understanding limitations and defining realistic clinical applications are crucial for the correct use of ONSD. Thank you for being a patient audience. Thank you so much.
Thank you, Dr. Sumit,
Thank you, ma'am.
for unraveling these mysteries of optic nerve sheath diameter. I think ultrasound is here to stay. I agree with you. It has a glorious future ahead, and as our expertise increases and the equipment becomes more and more portable, I foresee maybe in the years to come it would be in our pocket as frequently as we have our pulse oximeter. You know, we will probably be checking our optic nerve sheath diameters in the corridors or any which where. So, and most importantly, because it is non-invasive, I think that it does, you know, warrant the kind of importance we are giving it. Surely it will be extremely popular in the years to come. Thank you so much for this lucid talk. We once again leave the questions to the end, just keep noting them. We move on now to another topic that I think that this early recovery after surgery is something that has really changed the way we practice anesthesia in the last decade. Most non-neuro anesthesiology fields have already taken very warmly to it, and it seems to be more or less established among them, but somehow neuroanesthesiology seem to be a little wary of it, and we have really taken time to examine it and see whether we really have a place for it. And to tell us more about this very promising issue is with us today Dr. Arnab Das Gupta. Once again, he has been in our Max Super Speciality Nursery at some point of time. He is presently head of Department of Neuroanesthesiology at IBS in New Delhi, that is the Institute of Brain and Spine. A very passionate neurocritical care practitioner. And over now to Dr. Arnab.
Good morning everyone. First of all, I would like to thank ma'am for giving me the opportunity. She's the one who got me into neuro anesthesia, and some of my other teachers were also here. I think I saw Dr. Nidhi sometime back, and Keshav sir is here. So I'll be mostly speaking about my failures today. We have been hearing a lot about successes. I'll be speaking a lot about how why it is difficult to actually implement many of these things, and I want to take learning from these failures. So, ERAS, I have been obsessing about ERAS right from 2010 when I joined ma'am at Max Hospital, Saket. And around that time, the first articles had come out. And a few years before that, I underwent gallbladder surgery. And my anesthesiologist in Guwahati, he gave me a glass of carbohydrate juice, orange juice to drink 2 hours before the surgery. And I thought, what is this guy doing? And he said, okay, you just have it. And then later I learned that, okay, it's one of those things that are practiced as part of the ERAS guidelines. So as you can see from the slide, the main articles for the recommendations for ERAS from ERAS Society for neuroanesthesia, for neurosurgery, they came much later. And I'll be mainly focusing on the 2021 ERAS guidelines for lumbar spine fusion. Although there are lots of good review articles in craniotomies, including some from AIIMS. But it's not yet fully accepted everywhere. So, enhanced recovery of surgery, why is it done? Most of the articles focus on reduced length of stay, lesser cost, and they are mainly driven by insurance-based practice, where the patient does not pay out of the pocket. The insurer pays, and the insurer wants the patient to go home early and the hospital bills to be lower. Also, there is a secondary benefit that the medical complication rates are reduced by 30 to 50%, and this leads to a lot of satisfied patients. So this infographic basically takes us through the various stages of ERAS implementation, including the pre-admission, pre-operative, intraoperative, and post-operative places where they can be applied. Coming to ERAS in neurosurgery, so as I told earlier, this is relatively recently adopted, and adoption rates are really not that high. ERAS requires, it is written in many of the articles. If you search for ERAS, you can search it as enhanced recovery after neurosurgery. It's written as ERANS. So multidisciplinary implementation of evidence-based protocols is needed, and that's where the problem comes in. It's not just a neuro anesthesia where ERAS can be done. For ERAS to work, the neurosurgeon, the nursing team, the administration, all have to fall in line. Now, look at this article, Neurosurgery Perception of Enhanced Recovery After Surgery. In this questionnaire, out of 39 or 40 responses, only about 25 were doing ERAS in neurosurgery, and out of which all were doing ERAS protocols in spine surgery, but very few were applying it in cranial surgery. And this is US data. If you talk to any surgeon in India, if you talk about ERAS, you're probably going to get a blank look. I don't know those who are working with colorectal surgeons or others, if anyone is actually applying those principles. But most of the time I speak to orthopedicians or neurosurgeons or even general surgeons about ERAS, I get a blank stare. Now, all patients are not suitable for ERAS. So some of the protocols that have been reported, around 17, 18 protocols have been reported for craniotomy, and a lot of protocols are there for spine surgery. Inclusion criteria for cranial surgery have included patients in the 18 to 65 years age group whose ASA classification is between 1 and 3, usually single supratentorial intracranial space occupying lesions who are medically eligible for elective craniotomy, no emergency surgeries. Living near the hospital is a criteria, because when these ERAS protocols are implemented, they are talking about awake craniotomy patients going back home the same day. So in India, we are still sending our patients to ICU most of the time post craniotomy. So it's a difficult discussion with the surgeon much of the time. And living with a responsible caregiver is one of the things that if a patient is sent home early, there must be someone who can send the patient back to the hospital if some bad symptoms develop. Exclusion criteria include traumatic brain injury, uncontrolled seizures, serious brain disease, serious liver disease, serious kidney disease, patients with MI with multiple comorbidities. These are the patients with mental illnesses, those who have an anticipated difficult airway, where you want the patient to be under your care. And those with pre-existing neurological deficits, like our previous speaker has already spoken about posterior fossa surgery. You cannot possibly send a posterior fossa surgery home the next day. In spine surgery, the indications are more clear. Lumbar spine fusion surgery of 1 or 2 levels, with or without decompression, microdiscectomies. Then those simple surgeries, kyphoplasties and vertebroplasties, which are done frequently. Some do it under local anesthesia, some do it under general anesthesia, and some take a mixed approach where epidurals are used. Single-level cervical surgery, cervical surgery anteriorly or posteriorly, but then there is no clear-cut ERAS Society guideline for this. So this is the consensus statement for perioperative care in lumbar. This is by the ERAS Society. So we have, Godrej Almiras and Almiras. So when I talk about ERAS, before this seminar, before I prepared for this, I thought, okay, I know ERAS. But when I read about it, then I realized that, okay, ERAS with an R, it's a registered thing. And what we are doing is nowhere near what the society guidelines would like. So this is from the same article. So I'll be walking you through all these protocols. And when they have commented about all these small things, the level of evidence in each of these aspects, whether it is preoperative, intraoperative, or postoperative guidelines, the level of evidence is low to moderate. Only in a few things, in a few topics, the evidence level is extremely high. But the recommendations are strong, because when you implement them together as a bundle, then the magic happens, then things work differently. So preoperative counseling, this is the first topic, that Strong recommendations there for preoperative patient education in lumbar spine surgery. And this is where also the problem begins for the anesthesiologist. If you take a look at the new NICE guidelines, benefits, risks, alternatives, and doing nothing, brand approach, shared decision making. So you clear the doubts of the patient, you discuss the existing expected course of the thing. Many hospitals give printed pamphlets to the hospitals. Now, thanks to COVID, telemedicine is emerging as an option to counsel the patient preoperatively. This counseling thing requires coordination among anesthesiologists, neurosurgeon, nurses, physiotherapists, resident doctors, critical clinical care coordinators, and the literacy level of the patient is important. If a patient has come from a village and you explain the intricacies of intracranial surgery, it's not going to work. Then the functional independence of the patient. We get a lot of patients in which the patient does not know anything about the surgery. The relatives request us, "Inko nahi batana hai. The high-risk surgery, brain surgery, inko nahi batana hai." Now, how am I supposed to take the patient to surgery, get the surgery done, and wake up the patient? And who gives the consent? That's a legal problem there. You're supposed to take the patient, if the patient is M6, is conscious and awake, he's supposed to give the consent. And then we get international patients. There's a language barrier. Explain this to a patient from Iraq or from Sudan. You don't really know what the interpreter is telling the patient. Thankfully, prehabilitation is not an ERAS society recommendation for lumbar spine surgery yet. And the reason is, many of the patients, this works in other aspects of ERAS, in colorectal surgery or other fields where ERAS is practiced. But exercise, nutrition therapy, psychological preparation, all these things can really help the patient if you get time. Neurosurgery, patient has come, patient wants immediate surgery. International patients, outstation patients, someone has referred the patient to the surgeon is spending a lot of money to get the patient, and then if the surgery is cancelled and the anesthesiologist goes and talks to the surgeon, and this has happened to me many times in my student days, or in my learning days, even when I was working with ma'am or in my next phase, that if I go and speak honestly with the patient, there is a price you pay for honesty. And you have to explain things to the patient carefully. But at least we can get incentive spirometry started, and even that fails. You write instructions in your PAC note for incentive spirometry. When the patient comes to OT, you tell them they have not even seen the instrument. So a lot of things are there in practice. They are meant to benefit the patient, but they are not really done. If you do an audit, you see that it's not being done. Look at the recommendation of smoking and alcohol cessation, 4 to 8 weeks. Okay, we all know the benefits: better wound healing, lesser post-op pulmonary complications. And how do we go about it? We can go about it by practicing nicotine replacement therapy, which comes in many forms, including chewing gums, transdermal cutaneous patches, 7, 14, 21 milligrams, depending on how many cigarettes this patient smokes in a day. For alcohol, you can refer the patient to a psychiatrist who can consider disulfiram, cognitive behavior therapy, many vitamins such as thiamine and methylcobalamin. Most of our patients are already on thiamine and methylcobalamin and whatnot, pregabalin, gabapentin, benzodiazepines. Again, the problem occurs. So on the left side are the recommendations that I see in literature. On the right side, you can see in most of the slides the personal bias that I bring to the slides. Outstation and international patients. That way, if a patient coming from Bulandshahr or from Aligarh or from Iraq or from Sudan or from Kenya, you cannot just tell them, okay, you have come here, you have spent so many dollars, now you go back, come after 8 months, come after 8 weeks. That is difficult. And then management and neurosurgeons do not take a nice view towards the delay. That's where the problem occurs. If everyone is on board, then you can practice these things. Okay, at best what I can get is, I request the surgeon, sir, 2 din postpone karwa do. At least let the carbon monoxide wash off. Let us optimize the patient for 2-3 days. That will not increase the bill significantly, but you can have your cake and eat it too. And then referring a patient on alcohol for therapy, it is not taken too kindly in our country. There are many ways of assessing nutrition in these patients. It is recommended that you optimize the nutrition, and indicators of malnutrition include low serum albumin and transferrin and low lymphocyte levels. But again, implementation requires synergy among nutritionists, neurosurgeons, anesthesiologists, and the practicing team nurses. So here, what is actually right? How much calories should you give? How much protein should you target? SCCM guidelines say that you target a protein level of 1.3 to 1.5 grams per kg per day. Very difficult to achieve with a vegetarian diet. Immunonutrients. One of the earlier publications from AIMS, they recommended that immunonutrients such as arginine and glutamine and all that thing can be died. There is a lot of emerging research on symbiotics, prebiotics plus probiotics, to align the gut-brain axis in the right way and prevent the damage done by antibiotics. So some of these can be found in the ESPEN guidelines, but the recommendation for probiotics comes for liver surgery mainly. Now comes the most controversial topic. ERAS, American Society of Anesthesiology, ESA, and now recently ISA has come out with guidelines for preoperative fasting. 2 hours for clear fluids, 6 hours for light meals, 8 hours for a heavy meal, carbohydrate loading, exceptions apply. A patient is morbidly obese, a patient has lower cranial nerve palsy, you try and avoid these principles. But I have consistently and comprehensively failed to apply this over the last 15 years, because everyone knows that the patient has to be overnight fasted, and then your OT lists are fluid. The patient who is posted at 4 p.m. might be brought to 7 a.m. You don't know. And who decides whether the patient should eat? So the multiple specialty floor doctors, you have doctors going from one patient to another, they will tell, "Kisne bola hai? You have to stay NPO for 6 hours. Our nurses, our junior resident doctors, and the most common person for the same day admissions, patient is coming to surgery, the patient does not know the anesthesiologist, the patient knows the doctor, the surgeon. He will call the nurse's PA, and the surgeon's PA, the assistant, the secretary will tell her, "Khana nahi khana hai, nahi to anesthesiologist case cancel kar dega." So now implement the guidelines. So this is a screenshot from our own ISA guidelines. So I say that most surgeons tell me, hey, these are all Western guidelines, these are European guidelines, American guidelines, don't have work in our Indian population. So I showed them this. I forward the PDF to them. I said, it's our Indian researchers are saying that this is okay. So I respect that thing. Why don't you try and implement it? Okay, if you don't give anything, you don't want to give, and then the confusion comes. If you tell the patient to take clear fluids, they might take tea with milk and a biscuit. So this has happened to me. I've told the patient take either coconut water or water, stick to plain things, simple things, and then they'll end up taking tea with biscuit, and then you land in a soup, because now you have offended the surgeon. Pre-anesthetic medications. In the ERAS protocols, benzodiazepines are out. No need to give any anxiety. If you talk to the patient, you have prepared the patient mentally, they do not really require any sedation. But multimodal opioid analgesia, sparing analgesia strategy is employed, where you give paracetamol, NSAIDs, the gabapentinoids. These things they can be started before the surgery. The literature is not very clear on whether you should give PPIs, but it is a common practice. And many studies are now coming out with melatonin preoperatively. And in practice, you can implement most of this, because most of the patients who come to us for spine surgery are already on these things. In this context, I would also urge you to take a look at the Beer's criteria by the American Geriatric Society on the list of inappropriate patients, because most of the patients that we encounter above the age of 65 years. Now we have been told about a level of 7 grams per deciliter for anemia, but there is a strong recommendation to assess and correct pre-op anemia when patients are undergoing lumbar spine surgery. And I have seen a lot of orthopedicians doing the same, that they target higher threshold of 13 grams per deciliter and a lower level of at least 11.5. And this is very controversial. So when you have time for shared decision making and walking the patient through a month or so, then ideally you can give oral or IV iron supplementation and erythropoietin. But in the practical scenario, we really do not get time to do this. What we have done in many places, and what I've learned from some of my colleagues at Max Hospital Sagar itself, is ANH. So acute normovolumic hemodilution, where we used to take a pint of blood just before surgery and transfuse it back to the patient after surgery. So that saves on allogenic blood transfusion. Minimally invasive surgical techniques, use of cell savers, and these are different techniques that can be used to minimize blood loss. But you cannot really ask the surgeon to delay surgery to build up the hemoglobin level. Now, coming to some of the intraoperative measures. Despite the preponderance of literature on minimally invasive techniques, no technique is in literature superior to, whether it is invasive or non-invasive, the surgical technique. And it is something that is decided by the neurosurgeons. So they have to decide for it case by case. The recommendation states that absorbable sutures should be used rather than pins or non-absorbable sutures. And there is a recommendation for the use of fresh gloves for wound closure. Antimicrobial stewardship implementation is another difficult topic. What we want to give to the patient just before, within an hour of incision, is staph aureus covering antibiotic. And in neurosurgery, the recommendation is to give cefuroxime or cefazolin, but most of our surgeons prefer ceftriaxone. And this can be repeated at a 4-hour interval if the surgery is going to be long. Another point of failure here is that the maximum recommended dose of an antibiotic is 24 hours in clean surgery, but our surgeons tend to give the antibiotics for at least 2 weeks, sometimes 5 days, sometimes 7 days. It never stops. The antibiotics ends, and what that antibiotic does is it clears the normal gut bacteria. It really damages the microbiome, and it exposes the patient to the risk of infection by other bugs, which may not be as which are probably multi-drug resistant. WHO and CDC guidelines for SSI, they recommend chlorhexidine bathing 5 times before surgery. Again, this is difficult to implement in practice. Even in patients who are admitted the day prior to surgery or on the morning of surgery, implementing this, giving the patient a chlorhexidine bath is really difficult. There is only moderate evidence for antiseptic dressing of the operative area a night before surgery. There is also very controversial evidence on the use of intranasal mupirocin. ERA's guidelines for neurosurgery say that you avoid urinary catheterization, or if you have to put in a urinary catheter, take it out within 4 hours. Again, this is one point that is not in our domain. But what we can control is the anesthesia protocol, for which, for lumbar spine surgery, the recommendation is that we use modern general anesthesia, which is balanced general anesthesia, along with neuraxial anesthesia or analgesia, along with neuraxial blockade. So, sevoflurane, dexmedetomidine, ketamine, there's a lot of emerging articles on these favorable articles. Multimodal analgesia is to be considered to reduce the use of opioids, which means that you use everything from NSAIDs to paracetamol, and there are opioid sparing other options available also. As sir pointed out in his talk, in cranial surgery, we use a lot of scalp blocks, usually landmark guided, but sometimes ultrasound guided. Now, coming to the practice points on these recommendations, if we are using intraoperative neuromonitoring, then it is difficult to use neuraxial blockade. Neuraxial blockade is recommended because the wound recovery, the muscle soreness is much lesser, so the pain is much lesser. Invasive monitoring is avoided. We rarely put in central lines now, and when required, we put in arterial cannula. But even in craniotomies where the tumor is right under the surface, we can get away without arterial lines. And in this respect, there is a lot of literature on dexmedetomidine. I have personally not found any benefits of using intravenous lignocaine, and I do not have much experience with intravenous ketamine in the perioperative setting in neurosurgery. But supplementation with locoregional anesthesia or analgesia has multiple benefits. If the patient is not under the cover of some block, the surgeon can infiltrate the wound areas, and that leads to a reduction that has an opioid sparing effect. When you monitor BIS in elderly patients, those above the age of 65 years, or during TIVA, you find that the gas consumption goes down, which, apart from saving the patient from side effects, it also saves, this is a cost saving measure. And what we try to achieve is a TOF ratio of more than 0.9 at extubation, so that you know that when the patient is awake, when the patient has been extubated, you can start oral fluids early, because all these things, all these principles are, these are small, very small changes that are required in practice, but they're all interlinked. Each one, one implementation supports the other. So if your patient has a TOF ratio of more than 0.9 at extubation, then you are confident that you can start the patient early Regarding cranial surgeries, we have already discussed about scalp block, ultrasound guided scalp blocks, and I'll not go into the doses because we have already had an excellent session on this. But any scalp block, it has, if a patient undergoes GA, there is a dose reducing effect on the GA. If you're monitoring the BIS, you find that the requirement of general anesthesia goes down by at least 30 to 40%. So if your VMAP seminars are telling you that you keep the end-tidal CVO at 1.6%, you find that in an elderly patient of 70 years old undergoing resection for glioma, with a scalp block, your end-tidal requirement may be only 0.7, 0.8% when you are using BIS. So the cost of the BIS module itself is recovered by the gas you have saved during the surgery. So for lumbar spine surgery, there is a very strong recommendation for intrathecal analgesia, intrathecal morphine, epidural analgesia, and wound infiltration. And there is a weak recommendation for locoregional plane blocks like erectrospinal plane blocks or TLIF. And what is our experience? We have experimented with caudal epidural injections, with lumbar epidurals, and with thoracic epidurals. Neurosurgeons are quite comfortable with these blocks, and we have used mostly ropivacaine with adjuvants like nalbuphine and morphine at ridiculously low doses. Not only does it cut down on the general anesthesia requirement, it also cuts down on the amount of fentanyl required postoperatively. So there is a BIS, if you use BIS monitoring in these cases, there is a reduction of end-tidal gas concentrations or the TIVA dosages. Intrathecal morphine is safe.
Sorry to interrupt. Can you wrap up?
Yeah, sure, ma'am. Just 2-3 more slides. So intrathecal morphine, I don't have experience in neurosurgery. But the more experience is that with spine surgery, is with orthopedic surgery. There's a recommendation for hypothermia. Again, very difficult to apply if you can look at this slide here. For perioperative fluid management, we stick to RL or in spine surgery or Cabilite or Plasmalite A in but we try to use balance, the recommendation for use of balanced crystalloids. Post-op pain management is similar for intra-op management, balanced things with opioid-sparing usages. And here, continuous epidural catheter usage in spine surgery is difficult. Most surgeons do not accept, but a single shot epidural is well tolerated by the patient, and it has an opioid-sparing effect. For PONV, Apfel scoring, Coivaranta scoring is there. For PONV, the recommendation is that for first-line drugs like ondansetron can be used, but the rescue should be done with a second-line agent such as promethazine or metoclopramide. For VT prophylaxis, we use the Caprini score, and we use mechanical prophylaxis as far as possible. For there are times when we start the patient on direct or line with that, this is a point of contention with most surgeons. For ERAS implementation, standardized discharge criteria are needed, where clear medications are given to the instructions are given to the patient, dietary advice, constipation advice, when and where to seek help, and home visits can be planned. An integral component of ERAS protocols is auditing of what you are doing. So routine audit and feedback for implementation of the protocols are requested, and for audit parameters, around 90% compliance is needed. Outcome indicators that can be followed when you are implementing an ERAS protocol include length of stay, readmission rate, return to ICU rate, patient satisfaction surveys, patient reported outcome scoring. There's a quality management guru by the name of Donabadian who's on the structure, process, and outcome basis when implementation barriers to ERAS implementation have been studied. And for the structural requirements, medical resources shortage, lack of policy support, and outdated concepts have been cited as the most impediment factors. And in the processes, implementation of processes, poor doctor-patient communication, poor coordination among the multi-departmental team members, and lack of individualized management. And when outcome is studied, low compliance and high medical cost has been. So the current implementation of ERAS is still based on ideas rather than reality.
Arnab, I think we are running out of time.
I'm done, ma'am. This is the last time.
Getting repeated feelers from that side.
So this is the last line. We focus on the small, tiny gains, and a lot of these things add up to have an effect on patient outcome. And that's the basic principle of ERAS application in neurosurgery. Thank you.
Thank you very much, Dr. Arnab, for such a lucid presentation. Enhanced recovery after surgery is definitely the way forward. And I remember 5 or 6 years ago when I had attended a very big meet on enhanced recovery after surgery in Vietnam, and Dr. Joshi gave hours of lectures on the subject. One question about ERAS with neuro anesthesia just drew a blank. I was very dismayed. But in the last 5 to 6 years, I think that there has been a lot of heartening input, and many articles have come out in journals with more pressure of insurance agencies and our efforts to hasten patients' recovery and return to home. This is going to be the way forward, and I think that we need to dwell more seriously on how we can make it more pain-free for patients as well as ourselves. So enhanced recovery is here to stay. With that, we come to the end of the first sub-session of neuroanesthesia, and we move on quickly to the next session, which is going to address the ongoing and forever present debates in neuroanesthesiology. And we start with the first, that is total intravenous anesthesia versus inhalational anesthesia, never ending. Started, I think, maybe more than 2 decades ago, and we're still fighting about it. And to sort this problem out, we have with us today Dr. Ankush Arora. He is Associate Consultant at Max Super Specialty Hospital at Saket. And again, a very passionate, energetic young neuroanesthesiologist. Over to him, please.
Thank you, ma'am. Thank you, TASCON, for giving me this opportunity to speak here. So before starting my talk, I just want to have a little poll. Can we all have hands in the air? How many of us are actually practicing TIVA? So quite a lot of people, and we are comfortable, I think. So I think somewhere we'll be around 3rd and the 4th floor, that I want to do it and how do I do it. And at the end of 10 minutes or 15 minutes, let's say we are able to reach at the top. So there is always a tug of war between the TIVA and the inhalation in neuroanesthesia. And this is because we have 2 particular drugs, propofol and sevoflurane, which have led this war. And that is why there is a debate. So why is there a debate at all? Because in neuroanesthesia, we are not dealing with a normal brain. Had we been dealing with a normal brain, it wouldn't have been a problem. We could have used inhalation, we could have used a mixture of inhalation, we could have used intravenous, but it's not the case. We are dealing with an injured brain, and an injured brain has an impaired compliance and a raised ICP. So all our efforts in neuroanesthesia is to make the penumbra decrease to the minimum. The core is already damaged. We don't want the penumbra to increase in size, and that is why we need an agent which prevents secondary brain injury. So we all are well aware of the goals in neuroanesthesiology. I'm not going into the details of each and everything, but 2 most important things in distinguishing inhalation with intravenous is the smooth awakening and a rapid awakening. Again, an ideal anesthetic agent, be it inhalation, be it IV anesthetic, it should have a smooth emergence and a rapid awakening. And by this gave rise to the ideal anesthetic agent. Is it gas? No. Gas itself is shouting, gas always side effects. So the way forward in neuroanesthesia is total intravenous anesthesia. And it's the anesthesia via the intravenous agents only, as the name describes it. There is no gas or volatile agents involved apart from oxygen, and we can give it very well with the help of IV boluses, drips, syringes, or the fancy TCI pumps. So what are the ideal pharmacokinetics and or the characteristics of a TIVA agent? It should have a rapid distribution biotransformation. It should have an inactive metabolites. Most important are the 2 things, that it should have a clearance independent of duration of administration. We are using TIVA. We switch it off, the patient should be wide awake to tell us the GCS. The other thing is rapid recovery. Again, we switch it off, within minutes, the patient should be awake and telling his name. So what all drugs we have for TIVA? We are well aware of the propofol, the fentanyls, the muscle relaxants, the benzodiazepines. But 3 new drugs have been added to our armamentarium, which is the dexmedetomidine, ketamine, and the magnesium sulfate. And this makes TIVA even much more easy to use. As soon as we take the name of TIVA, the two drugs that come in our mind are propofol and remifentanil. And why is that? This is because of this. We want to use a drug in TIVA that has a very small context-sensitive half-time. Context-sensitive half-time is the time it takes the drug to decrease to 50% of its concentration in the plasma. On the y-axis, we have the context-sensitive half-time, and on the x-axis, we have the infusion duration. In this, we can clearly see propofol, and as the infusion duration is increasing, the context-sensitive half-time is not increasing much. So that is why that name TIVA is consistent with propofol, and that is why the name propofol comes up. Another important thing to note here is of ketamine. Ketamine hasn't still lost its value in neuro anesthesia, and it is coming back. It is the context-sensitive half-time of ketamine is even better with propofol, and as the duration of infusion is increasing, the context-sensitive half-time is even less as compared to propofol. Coming to the opioids, as I said, propofol, remifentanil, TIVA. So remifentanil is the drug of choice, but again, it is not easily available in our country, and wherever it is available, the cost is a lot. So remifentanil is because it has the minimum context-sensitive half-time when compared to fentanyl, and that's why we shifted from propofol, fentanyl to the cocktail of KPD. KPD is ketamine, propofol, and dexmedetomidine. In our institute, we were very well using a combination of propofol and dexmedetomidine for TIVA. We have recently done cases in ketamine as well, and we have found good effects of that. And why is we using KPD? Because the combination of these drugs permits lower dose of each individual, and thereby reducing their adverse effects on the hemodynamics and the respiratory effects. By using minimum doses of all the three, it provides excellent analgesia and the anesthesia, which is our goal, and the individual dosages are decreased, providing rapid recovery. These are the dosages. I'll come to it. So what are the all advantages that we get with TIVA? Few of the important advantages are there is no risk of malignant hypothermia. There is very less effect on the post-operative delirium. It can be easily used in patients who have a long QT syndrome. It causes no or very less operating room pollution, which is the hot topic these days. It causes better preservation of cerebral autoregulation. It reduces the stress response and causes very less post-operative nausea and vomiting. Another important thing to note here is that TIVA is easily titrable, and this is specifically required in a case of neurosurgery. And why is that? It is because a case in neurosurgery requires the same depth of anesthesia. There are four particular points in which the noxious stimulus is the maximum, and we require something that can be given as a bolus or as an infusion, which and as soon as we increase the dosage, it reaches the effect concentration immediately. So what are those 4 points? It's the induction, pin fixation, the dural opening, and the dural closure. So at these 4 points, we want a drug which immediately when we give reaches its peak plasma concentration and provides the desired effect. And this is only possible with intravenous route and not with the inhalation routes. That is why TIVA is advantageous. The other disadvantages of inhalation, we are all aware that nitrous, isoflurane, and desflurane should not be used because they cause vasodilatation, even when used in a MAC of 0.5 to 1 and cause an increase in ICP. But again, I said that propofol and sevoflurane are the things that we are having this debate today. It's because sevoflurane doesn't cause much change in the cerebral blood flow. It rather decreases the cerebral metabolic requirement of oxygen and thereby prevents any increase in ICP. And that is why if we want to use, we use sevoflurane, but provided it is used in the MAC of 0.5 to 1. We cannot go beyond a MAC of 1 as it will cause massive vasodilatation, causing an increase in the ICP. This was again, this is a paper by Dr. Prabhakar et al., which says intravenous versus inhalation technique for rapid emergence of anesthesia in patient undergoing brain tumor surgery. They compared it, 15 RCTs, which included around 1833 patients, and what they found was the time to emergence from anesthesia was not different when sevoflurane was compared with propofol. They even said the brain relaxation was the same when propofol was used with, when propofol was compared with sevoflurane. But yes, they found very less nausea and vomiting in the post-operative period in the group where propofol was used rather than the sevoflurane. This is another article of 2017, which target controlled infusion propofol versus the sevoflurane anesthesia for emergency traumatic brain surgery. This was published in 2007, and what they found was that if inhalations are being used, the condition of the dura at the first burr hole, when the first burr hole is made, we should look for the dura and ask the surgeon whether the dura is tense or soft. And if he says the dura is tense, then we shift to TIVA. So that indirectly again means inhalations are not to be used and TIVA is the way forward. This is a fairly recent article of comparison of total intravenous anesthesia versus inhalation anesthesia on the cerebral hemodynamics in patients undergoing emergency craniotomy. This was published by Dr. Preeti et al. And they found that TIVA provided better brain relaxation and reduction in ICP as compared to the inhalation. And the ICP measured at the dural opening was significantly less in the TIVA group, and the CPP was much better and well preserved in the propofol group. So as this has already been discussed, that there are certain cases in neuro anesthesia which we cannot absolutely use inhalation, even if we want to. The first and the foremost is for neuro monitoring. For a neuro monitoring, an ideal would be a propofol or a fentanyl infusion, and again, dexmedetomidine can be used here. The other is awake craniotomies. No role of inhalation, whether you give a sleep awake or a sleep cycle or the awake. Again, the Brain Trauma Foundation guidelines told us that TIVA is the way forward. They said this Tier 2 therapy for resistant ICP management is to switch off all the anesthetic, IV inhalation, to switch off all the inhalation agents and switch over to TIVA or increase the dose of propofol if it is being already used. So, is it feasible to say TIVA is the God? No. Everything and anything doesn't come with all the positive sides. It's not very easy to measure the blood concentration of IV agents in a case of neuro. Why? Because BIS cannot be applied to each and every case because we are sharing the surgical site with the BIS area. Most of the cases they do a frontal craniotomy where BIS cannot be applied, or even if the BIS is applied, it gets damped by their repeated cleaning with betadine and other things, and it doesn't give a very correct value. So it is very difficult to get the concentrations of IV agents. Again, in our country specifically, TCIs are not easily available. In our center also, we don't have TCIs. We are using the syringe pump. And as soon as they are available and become cheap, I think TIVA would be even more easy to use. The third and the fourth most important thing is awareness. This was an audit done by the National Audit Project NAP5, and they found about 20% of the patients who underwent TIVA had an accidental awareness. And the major reasons they found was technical errors and poor application of the knowledge was the major cause of awareness using TIVA. And 75% of these cases would have been prevented if we were provided suitable education and training. And the other two are the costs, obviously, and the recent hot topic is the opioid-induced hyperalgesia, and that is why I think we are heading towards opioid-free anesthesia. So what do we practice in our center? We do about 90% of cases and only TIVA. We use sevoflurane. If we use sevoflurane, we make it a point to keep it at a dose of less than 0.8 MAC. We give it with the help of syringe pump. This is a typical OT of ours in which we are using propofol and a fentanyl infusion. We have the TOF. In this case, we applied the BIS also, which is providing adequate depth of anesthesia. The point to be noted here is that we can see yellow, that means sevoflurane was being used here. So what we do is we induce the patient with propofol, And by the time the patient is induced, we switch on the sevoflurane. After the induction and intubation has been done, we secure another IV line, and after that we start the IV propofol infusion, and at that time, after 10 minutes of starting that, we switch off the sevoflurane. So in that duration, when we are making our lines, putting our lines, the patient doesn't have any awareness. The MAC doesn't reach to the values which are bad for the brain, and we get it, and by the time we are making positions for the duras, for the surgeons to start operating, the sevoflurane is totally out of the system, and we have total intravenous anesthesia. Another important point here to point out is, as I have already told, that the noxious stimulus doesn't remain same in a neurosurgical case. So we need a drug which we, when given as a bolus, reaches its peak effect immediately. So in this case, when we were making the position, the BIS increased to 61. We gave a bolus of 30 milligrams of propofol, and within seconds, not even minutes, the BIS came back to 44, and we were happy. So the other ideal way of giving TY is through a targeted controlled infusion. A targeted controlled infusion is an infusion controlled to achieve a preset drug concentration in the plasma or the effect site. We don't have to do much. We have to just put the weight, the height, and the plasma concentration that we desire. For example, for a propofol, it is 4 to 6 micrograms per ml. We just put it in the software or the TCI that we want a plasma concentration of 4 to 6 microgram. Let's say we put it 4. The software and the infusion pump will do all the job for us and will give the infusion rate at which it has to be started. And this is based on the 3-compartment model of the TCI pump. In this, when we give a bolus of the drug, the first is the central compartment which gets saturated, which is the plasma, which then equilibrates with the effect site, which is the brain, and then it is redistributed to the rapidly equilibrating compartment, which are the muscles, and the slowly equilibrating compartment, which is the fat. So these are the various syringes, TCI pumps, and finally concluding that TIVA is the way forward. We like it, we don't like it, we are not familiar with it, but we have to go for TIVA in neuro anesthesia because it is patient friendly, it is anesthesiologist friendly, it is surgeon friendly, economically friendly, and environmental friendly. So what is the future? Future is an auto TIVA through the artificial intelligence with the help of TCI and BIS. In this, we don't have to change the concentrations also. It will be a closed loop where we can easily see that the BIS monitor is incorporated into the software, which is again incorporated into the TCI pump, through which the propofol concentration, by changing the infusion pumps directly, it will be changed, and the BIS will be maintained at a depth required. The other thing is, like vaporizers, the syringe pumps and TCI systems will be integrated in the anesthesia workstations very soon. Thank you. So I hope we have reached somewhere closer to the top, if not the top.
Thank you, Dr. Ankush. I think what is good for the brain and good for the environment is definitely something that is here to stay, and maybe more hands would go up in favor of TIVA if we did the poll again. So without wasting any more time, thank you once again for an excellent lecture. We now move on to the next very debatable topic, forever at war, mannitol versus hypertonic saline. And to address this issue, we have with us today Dr. Nidhi Gupta. She is consultant neuroanesthesiology at the Apollo Hospital here in Delhi, and she will try and remove some cobwebs that still persist regarding this issue.
Thank you so much, ma'am, for this kind introduction. And at the very outset, I would like to thank the organizers for giving me this opportunity. And I'm so glad to have Kavita ma'am as my chairperson. She's been my mentor, and I've been privileged to work with her at Max Saket. So, well, I'm going to talk about this age-old debate of mannitol versus hypertonic saline. And I actually fear this is a very theoretical and apparently a boring topic. And I try to keep it not too repetitive, and I just hope in the end we are able to reach to a consensus. So to begin my talk, we all know that mannitol and hypertonic saline, both of these are the known hyperosmolar agents which are an integral component of osmotherapy for intracranial hypertension in neurocritical care units worldwide. So they are recommended early on. As you can see, they are recommended somewhere in the tier 1 therapy. They are preferred for an early control of intracranial pressure at a time when the patient needs an immediate control of his cerebral dynamics. They have a predictable therapeutic effect and a wide therapeutic margin. So, though we know that the ICP lowering effects of mannitol and hypertonic saline are there, still, till date, there is no literature which tells us about a clear-cut superiority of one agent over the other. So, we've been using, like controlling of intracranial pressure for us neuroanesthetists, it's like a bread and butter. We do it in our OTs, we do it in our ICUs, and we have a long road of clinical experience of using both the agents. So why is it that despite a long clinical experience, we still are not able to decide which is our best agent to go for? And the quest for an ideal osmotherapeutic agent is still on. Now you can understand the sheer dilemma of choosing your, say, salt, which is the hypertonic saline, or sugar, which is your mannitol. In your neuroanesthetic drug armamentarium is by just the sheer number of systematic reviews and meta-analysis we have in the literature. You just go and check the PubMed over it, and there is a plethora of literature over it. So we can't go on to the decade-long literature. I have just picked up few of the systematic reviews which have been published in the last 3 years. Hopefully, they are an amalgamation of the recent literature over this topic. Just a brief synopsis, not too much into literature. So we had this Cochrane analysis which was published in 2020, and which says that there is a weak evidence to suggest that hypertonic saline is no better than mannitol in efficacy and safety in the long-term management of acute traumatic brain injury patients. Following this, we had another systematic review which was published in Journal of Intensive Care in year 2020 itself, which evaluated the effects of hypertonic saline versus mannitol in its pre-hospital emergency department and intensive care unit settings. And this systematic review was of the opinion that there was no significant difference in terms of improved clinical outcomes and mortality reductions in traumatic brain injury patients. Still no evidence. Another review, which was published in Medicine in 2020, in traumatic brain injury patients itself, and which is little different, which says that 3% hypertonic saline has a more sustained effect on ICP and can effectively increase CPP, something to actually look forward to. Another one, published in Journal of Neurosurgical Anesthesiology, our main journal, and it was published in 2021. It was again done in traumatic brain injury patients. It again goes back to saying no significant difference in mortality and neurological outcomes. Though there is a possible advantage of hypertonic saline over mannitol, there is a trend towards reduced mortality, beneficial effects on CPP, and to a lesser extent ICP with hypertonic saline. Another latest one, published in year 2022, this is about the equimolar hypertonic saline and mannitol for brain relaxation in elective surgeries. This said that again there is non-statistically significant tendency for hypertonic saline to achieve better brain relaxation scores. Mannitol, because of its diuretic effect, was associated with higher urinary output, lower perioperative fluid input, and higher CVP values were associated with hypertonic saline administration. And the last, I got the recent one, published recently in journal Frontier Surgery. It says, no significant difference on the favorable outcome, mortality, and ICP and CPP values at a longer term, more than 90 minutes duration. But early on in the treatment, within a duration of 30 to 60 minutes, hypertonic saline favors better. So we have all this literature, and again, trust me, there is no clear-cut evidence coming out of this to give us a clear-cut guideline so that we can base our treatment decisions on. So why is that so? Because most of our literature is based on systematic reviews. There are no randomized controlled trials over this topic. The studies have their limitations. There are methodological flaws over it. And maybe because there is a complexity of the underlying disease processes. the interactions between multiple treatment interventions. You're using osmotherapy, you're using drugs, barbiturates, you're hyperventilation. So using a lot of treatments together to control ICP. There is never a single agent going on at the same time. So it's very difficult to pinpoint your fingers on saying that yes, hypertonic saline is improving or mannitol is improving. So that is always a problem. There is a lack of clinical outcome measures. Most of the studies we have focus on ICP, PbTO2 or CPP as values. There are very, very limited literature which says about mid-term or long-term recovery scores. When it comes to studies for hypertonic saline, there are studies which have solutions which have added colloids, and the results are not transferable to hypertonic saline. Again, with hypertonic saline, there is a wide variation in the concentrations which are available, and the dosage ranges is very, very variable in the studies. There is a very poor reporting of adverse events. Few of the studies would be talking about adverse events, and again, there is not a very statistical difference coming out of it. There are a small number of cases in each of the treatment arm if we have any RCT, and there is inappropriate choice of statistical models when we talk of meta-analysis. So, we are clinicians, we are basically relying upon the evidence-based medicine. We go through a rigorous review of literature, we look for the evidence-based guidelines, and that's how we base our treatment recommendations on. So we look forward to the Brain Trauma Foundation guidelines, and they are not very helpful. Some evidence is there in favor of hypertonic saline. So luckily for pediatric traumatic brain injury patients, we do have a class 2 evidence to support the use of hypertonic saline for treatment of ICH. But again, there is insufficient evidence to support or refute the use of mannitol or other hyperosmolar agents. The situation in adults is not very promising at the moment. We have insufficient evidence from comparative studies to support a formal recommendation as according to the latest Brain Trauma Foundation guidelines. And there is no evidence so far to support the use of any specific hyperosmolar medication in this subgroup of patients. So we don't have guidelines. What do we do? So here comes our clinical understanding. We have to actually look into each patient profile. How is the patient? What is the disease? Where is he lying on that disease spectrum? What he immediately needs? And our basic clinical go back to the pharmacology. Try and understand the drug pharmacokinetics and pharmacodynamics. You have to work according to your local institutional protocols. You have to see what is easily available to you, which you can easily procure from your pharmacy, and of course your clinical experience. So just a brief review of pharmacology. It's again a boring topic, but we'll just go rapidly over it. We need to know the mechanism of action of both the drugs. If we know how are they acting in the body, then only we can choose the better one out of that. So mechanism of action, 20% mannitol. It has a biphasic effect. First, it has a direct osmotic effect on the brain tissues, on the astrocytes, the glial cells, and it works on the areas which have an intact blood-brain barrier. Along with that, it also helps to open the tight junctions within the blood-brain barrier to maintain that osmotic pull and to draw the water from the intracellular compartment to the intravascular compartment. It has a reflection coefficient of 0.9, which is fairly good. And that, that it maintains its ability to remain in the intravascular space and continue this osmotic drag of fluid. Along with that, there are other few mechanism of actions. There is a redistribution of cerebral plasma volume. It increases your cerebral blood flow, and then concomitantly, there is a vasoconstrictive response on the cerebral vasculature, effectively reducing your ICP. It has a rheological effect. The RBCs are shrunk, the viscosity is decreased, and your oxygen delivery to the cerebral tissues is improved. And at the cellular level, it has a free radical scavenging effect. Now we look at the hypertonic saline. It comes as a variable, it comes at a very variable concentration ranges from 2% to 23.4%. It has a similar effect, it has a similar mechanism of action, a direct osmotic effect, a rheological effect, same as mannitol. But the better part here is a higher reflection coefficient, 1. It is as good as saying theoretically, yes, you are the ideal osmotherapeutic agent. So that later on we can see that it leads to a more sustained effect on ICP reduction. And at a cellular level, it increases your extracellular sodium levels, which stabilizes your resting membrane potential, reduces cell hyperstimulation, and ultimately apoptosis. Now, since it is a pro and con debate, it's basically mannitol versus hypertonic saline, so we go back to the pro and con debate. So coming to the pro and con of mannitol, what are the pros? Why should I be choosing this drug? So we really have a very good experience. We've been using it over years as a first-line agent in most of our patients. It has a stable shelf life, it is chemically inert, and it effectively decreases ICP in a dose-dependent manner, proportional to your degree of intracranial hypertension and to the dose you're using. It can be given very easily. All you need is a peripheral IV cannula. And since it has a diuretic effect, it can be used in patients with heart failure easily as compared to the mannitol. And we will see that it is preferred over hypertonic saline in patients with coagulation disorders like thrombocytopenia. What are the disadvantages of using it? Why should I not be using it? So we need to understand that though it is a very good osmotic diuretic, what is the first initial response of mannitol administration in the body? It has a good molecular size. It has a good reflection coefficient of 0.9. So it is there in the intravascular volume. It will transiently increase your intravascular volume. And patients who have a very compromised cardiac status, this transient increase may be deleterious to them. So you have to be very careful. Do not give a very rapid infusion of mannitol, because it can precipitate hypovolemia, it can lead to pulmonary edema and heart failure in patients who are predisposed for them. But this is a transient effect. Later on, it is taken over by a sustained diuretic effect, which is prolonged. And patients who are hypovolemic, the patients have been running from one hospital to the other. Nobody bothers to, check whether they're receiving fluids or not. We are just pushing on to the mannitol. Every hospital he goes in, first thing, give mannitol. Nobody bothers whether he's receiving fluids or not. So they turn out to be hypovolemic and then hypertensive. Again, a very bad effect of mannitol. It can lead to metabolic derangements and can precipitate acute kidney injury, which is higher in patients with a higher osmolar gap or a serum osmolarity of more than 320. And we all know that it has a tendency to cause rebound cerebral edema. Over a period of time, with repeated administrations, it may seep into your cerebral tissues and cause rebound edema. Coming to hypertonic saline, the pros, definitely, has a better effect and a more sustained effect on ICP control. And as we see that compared to mannitol, it is not a diuretic per se, and initially it is a very good intravascular volume resuscitation. So it will increase your intravascular volume. It can lead to an increase in mean arterial pressures. Your stroke volume go high, your cardiac output goes high, and effectively your CPP will be better off with hypertonic saline. And reflection coefficient of 1, there is a low risk of rebound cerebral edema. It's a less potent diuretic, better cardiac status, and it can be used in hemodynamically unstable patients where maintaining your intravascular volume is very critical to us. So it can be used easily in patients with septic shock, TBI, and subarachnoid hemorrhage. It has an immunomodulatory effect, and it is also effective as a rescue therapy in patients who are refractory to mannitol. About the cons, there is a huge confusion regarding its dosages available, what should be the optimal concentration to be used, dose to be used, and now we are talking about the route also, whether we should give it as a bolus or as a continuous infusion. It needs a central venous access, it causes very bad phlebitis. Rapid correction of serum sodium levels can cause central pontine myelinolysis. There is hyperchloremic metabolic acidosis when we give in large amount, AKI and coagulopathy. And excessive increases in serum sodium levels may lead to hypovolemia. And if you're using in patients who have sort of deranged cardiac profile, then we have to be using it under strict cardiac monitoring. Now, just because this wasn't something I found important to discuss, that both we say that mannitol and hypertonic saline can predispose to AKI. So if actually I'm really worried about my patients with acute kidney injury, what should I be going for? So I found this interesting post-hoc analysis of the erythropoietin traumatic brain injury trial. And this says that early use of mannitol, but not hypertonic saline, was independently associated with an increase in acute kidney injury. So this is basically a post-hoc analysis. It's not talking about causality. It's just not saying that, yes, it is causing this. But again, something we have some thing to think for, that if I have a patient with AKI, I can easily, safely go for go for hypertonic saline than the mannitol. So how should be going about it? Just a brief. If we have a patient with intracranial hypertension, mostly what we do is a bolus of IV 20% mannitol, and it is later in emergency department, which is followed by a bolus dosing of 0.25 to 1.5 gram per kg every 4 to 6 hours. And we need to stop it if the serum osmolarity is more than 320 milliosmoles, or the gap exceeds more than 20. Hypertonic saline is used as a rescue therapy. This is what we generally do. Now, when should I be going for hypertonic saline? It's nemesis. I would love to use it as a first-line agent in patients who are hypovolemic or has an AKI or has a risk factors for AKI. And it can be used as an continuous infusion or a 150 ml boluses timed every 4 to 6 hours. And I have to reach a target serum sodium of 145 to 155. And if we are lucky to have 23.4% saline with us, it is really good in emergency situations, and it can actually reverse your transtentorial herniation within minutes. So to conclude my talk, till date, after all this rigorous review of literature, we do not have any specific recommendation to select hypertonic saline or mannitol as a first-line agent for patients with intracranial hypertension. And frankly speaking, there is no difference between hypertonic saline and mannitol when we terms in a larger perspective of functional recovery and mortality benefit of patients. But to be on a very practical note, for emergency initial resuscitation, mannitol is here to stay. And as a rescue agent, hypertonic saline, I would really love to use it. And just for the sake of completion of the talk, we really should be doing some prospective RCTs on this, but difficult. It's a far-fetched dream. What we can actually hope on for is a very good quality prospective observational studies, which I hope would bring an end to this debate. Thank you so much.
Thank you, Dr. Nidhi. It was an excellent talk as always and extremely well researched. I think academics is Nidhi's forte. She has many chapters and articles to her credit, and she's living up to that reputation. Thank you once again. So now, without wasting any more time, we move on to the last topic of today's session, and that would address things not to be done during neurosurgical cases. And to talk about this, we have with us Dr. Ashu Vadera. She's with us at Max. She's a principal consultant at Max Super Specialty, and very active member of all our debates in our OT as well as neurocritical care unit. So on to Dr. Ashu.
Good morning once again. Thank you, team TASCON-2022, for making me a part of this academic forum. And special thanks to my dear friend, Dr. Sumit Kalra, whose infectious enthusiasm rubbed off on me. And here I am in front of you talking about what not to do in neuro anesthesia cases. So all my previous speakers have spoken on what has to be done. My topic is a little bit different, and I hope I'll be doing justice to the topic. I'll go from PAC to induction, position, maintenance, and extubation, and tell you about what is not to be done in neuroanesthesia cases. And I have used my personal experience along with the recommendations that are currently available. So during PAC, I tried to focus on things which are important to our neuroanesthetist. So I'll be focusing on carbon dioxide, blood pressure, fluid, temperature, and time. This time is in relation to the time that we spend on PACs, where to hurry and where not to, not to hurry. So starting from PAC, do not miss out on your airway assessment. This is very important, as we all know. This is especially true for cases who have a raised intracranial pressure and those who have a very significant midline shift. If you are not prepared, then we'll land up causing more secondary damage to our patients. And airway assessment is also very important in cases of patients who have been posted for an upper cervical spine surgeries and also post-operative upper cervical spine surgeries. Do not forget to ask about a past history of radiation to head and neck and a tracheostomy. Make sure that the investigations and patient are the same. Look for the tumor location because it gives you a fairly good idea of about the amount of blood loss that is to be anticipated, and also it helps you in preparing for a post-operative mechanical ventilation. consider the patient profile in relation to the duration of the surgery. This is the time where you can discuss with your surgeon regarding an alternative procedure if possible. And do not forget to document your preoperative neurological status, which includes your GCS, motor power, pupillary size and reaction. Why this is important? Because later on, at the time of extubation, you're going to compare the neurological status with this. So I have just, taken up a patient of ours who was a post-operative case of an occipitocervical fusion. And she came back to us with a history of dysphagia, and the surgeon planned for a osteophyte drilling at C5-6 level. This is at the lower level. Now we missed this, seeing this X-ray in the preoperative period, which was showing a bigger osteophyte at the C1-C2 junction. Now when we took up this patient for anesthesia, the bag mask ventilation was extremely, next to impossible. And LMA could not be inserted. It was not going beyond a particular point in the mouth. Then we ventilated this patient with the nasopharyngeal airway, and we achieved a good ventilation. We tried for a fiber optic intubation, but there was a lot of edema in the oral cavity, and it was so difficult to reach the epiglottis. So finally, we took the decision of postponing the case and for planning an elective tracheostomy and a subsequent surgery. So the entire point is that, do not miss things like this, especially in an upper cervical spine surgery cases. The other point that I was talking about was where a thorough PSC is not feasible. This is in cases of stroke and EDH. In a stroke, expect comorbidities and no time for optimization, and be prepared with MAC with or without sedation versus GA, depending upon how your patient profile is at the time of presentation. Everybody talks about pre-medicating the patient. I am talking about where not to pre-medicate, and this is where there is a raised ICP or where there are large tumors with significant midline shift. If you pre-medicate these patients, then there are chances of a neurological worsening, which is secondary to a respiratory depression, so try and avoid it. However, if in your preoperative area you find that the patient has hypertension and tachycardia, which is attributable to anxiety, then you might pre-medicate, but don't let it go unsupervised. And also always remember that in the elderly, the benzodiazepines will have a prolonged sedative effect. When you wheel in your patient, then you put in your monitors. In monitoring, do not forget your arterial and CVP lines whenever they are indicated. Remember not to put your ECG electrodes in the surgical field. This is especially true for spinal surgeries and in cases of spinal DSA. Try not to forget about your depth of anesthesia and use intraoperative neuromonitoring whenever it is indicated. And most important monitors are your ears and eyes. To give you another example, this was a young patient of ours, 34 years old, posted for a styloidectomy for an Eagles syndrome. Now this patient was having an uneventful kind of a surgery when we suddenly noticed a gush of blood coming in the suction, and the patient lost around 400 ml of blood. And simultaneously the monitor gave us an alarm for hypotension. While the surgeons were managing the blood loss or finding the bleeder, we managed the hemodynamics with the help of crystalloids. Perhaps this, and the patient was extubated comfortably at the end of the surgery. However, this could not, we might not have had the same outcome had the patient been anemic or had, comorbidities and could not tolerate even this much of blood loss. So now coming to induction should not be turbulent and should follow the goals of neuro anesthesia, which are maintenance of CPP, avoidance of intracranial hypertension, and provision of optimal surgical condition in order to avoid further progression of a pre-existing neurological insult. Now, the things that need to be avoided are hypoxemia, hypercarbia, any sympathetic stimulation that arises from laryngoscopy and intubation, and do avoid a rapid and an untitratable kind of an induction. I'll not talk about, the various drugs that are present in the armamentarium of an anesthetist, but I'd like to put in a word for a drug which has been much maligned in neurosurgery, and that is ketamine. Ketamine, contrary to the conventional teaching, is showing a resurgence. It is showing a neuroprotective effect and has been found to be useful in cases of refractory and super-refractory status epilepticus. It has found a role in prevention of DCI. It can be used in amplification of evoked potentials under GA. And of course, it is an excellent analgesic in sub-anesthetic doses, well utilized in post-spine surgeries. So maybe the nail on the coffin can still wait. Now, as was mentioned by Dr. Keshav, neurosurgery is, in this, you'll find all kinds of various positioning: supine, prone, lateral, semi-recumbent, recumbent, anything that you can think of. So the only things that I'm going to talk about is, these patients are going to be at a distance from you. Just look at this picture. Look at where your anesthesia machine is and where the head of the patient is, where the surgeon is operating. So since you're going to have a remote access to the airway, don't forget to secure the airway. Another patient undergoing a spine surgery under O-arm. This is the IV stand, and the hands of the patient are somewhere here. That's where your IV cannula is. So do not forget to make provisions for IV extensions. Again, longer circuits. See the distance between the anesthesia machine and the head of the patient. Don't forget to make a provision for longer circuits, and always protect the pressure points. Also, make sure that your eyes and your pressure points are free. Now, this has already been taken up by Dr. Ankush. The important point is that you must not forget your critical moments during the course of a neurosurgical procedure. You need to know, understand, and retain where you need to, deepen your anesthesia and where the extra analgesic has to be given. And of course, during maintenance, use any procedure, use any drug, but do make sure that you give the surgeon a good surgical exposure, provide neuroprotection, and allow for a quick wake-up and a neurological recovery while facilitating neurophysiological monitoring. Now, does one shoe size fit all? No, of course not. So similarly, the blood pressure goals have to be individualized. The main goal of blood pressure is to maintain the cerebral perfusion pressure. Keep your map around 20% of the baseline. Do not be overzealous in controlling your blood pressure, because once your dura is opened, your blood pressure is going to come crashing down. And also, do not overlook the condition for which you're getting the surgery done. I've given you a few examples here. Like for an acute ischemic stroke who's planned for a thrombolytic therapy, the BP should be targeted for somewhere around less than 185 to 110. But remember, again, these are not absolute values. If the BP is, say, above 220, 240, then there should be no abrupt lowering. Get it down gradually by 15% initially. Also, like in acute hemorrhagic stroke, we are targeting for somewhere around less than 145. But again, if the starting BP is very high, get it down by 15 to 20% initially. According to the Brain Trauma Foundation guidelines in TBI, the aim is to maintain a CPP of 60 to 70. We all know that for SAH, before clipping or coiling, the target of SBP is less than 160. And post-intervention, we need to keep our maps higher on the higher side, that is around 100. A few pointers about neurointervention, which you must not forget. In carotid stenting, always be prepared for bradycardia. Post-AVM and post-carotid stenting, we need to have a good BP control in order to watch out for, prevent perfusion pressure breakthrough. And a small word about vein of Galen, just keep your BP low during the procedure. Ventilation, a very powerful tool in the hands of the anesthetist. So do we hypoventilate? Do we hyperventilate the patient? There is a condition where we need not worry about hypoventilating or getting the carbon dioxide up. And this is in cases of, a transsphenoidal approach to pituitary tumor. Here, hypercarbia may be helpful in accessing the tumor. Now, hyperventilation. Do you keep on hyperventilating a patient? No. See, remember that this is a temporary measure. This is a bridge, not a destination. So the goal is to facilitate the final intervention to take place, buy you some time before before your intervention is going to take place. You need some time to protect the brain. So the goal is to achieve a ETCO2 of 25 to 30 while reaching a PaCO2 of 30 to 35. But where do you use it with caution? In stereotactic procedures. Once your frame has been placed, the coordinates has been placed, now you start hyperventilating a patient, the coordinates are not going to work because of the brain shift. So remember to use it with caution in stereotactic procedures. How about temperature? We all know that even mild hypothermia will exacerbate the brain injury. So the practical step is to avoid intraoperative temperatures of more than 37. And how about hypothermia? It has been a robust tool for neuroprotection in laboratories. However, the studies are kind of variable and we are still debating whether it is still useful for neuroprotection or not. What about fluids? The goal of using fluids is to maintain an adequate cerebral perfusion while providing a good surgical environment and maintaining a normal blood volume while preventing a decrease in plasma osmolarity. Why? Because a reduction of plasma osmolarity is going to increase your cerebral edema. So what do we avoid? Any hypoosmolar fluids, say for example, ringalactate. Normal saline, isotonic, yes, we can use it, but the most important side effect is hyperchloremic metabolic acidosis. So currently, the flavor of the season, balanced salt solution is what we are using. Now we have decided, before that, the colloids and albumin. The current guidelines are not recommending any use for colloids or albumin in neurosurgical patients. However, in SH patients who have no pre-existing renal insufficiency, colloids may be used. Now, once you've decided on the fluid, the next question that comes to mind is whether to give or not to give. So we have, over a period of time, gone from restricted to liberal, and there have been proponents for both the kind of therapies, that some favor restricted, some favor liberal fluid therapy, but they have both their advantages and disadvantages. So the current strategy which is being used is the goal-directed fluid therapy by using parameters like stroke volume variation, pulse pressure variation, and the pleth variability indices. Now, what at emergence, what we do not do is let the BP rise. Don't let your patients struggle. Anticipate that the blood pressure is going to rise because there's bound to be a rebound hypertension as you're switching off your volatile agents and your analgesics or your IV agents. So be prepared with drugs like labetalol that have easy titratability, dexmedetomidine, very powerful, very useful drug, and you can also think of scalp nerve blocks as a transitional analgesic. Remember, at the time of extubation, all our extubation criteria like tidal volume, respiratory rate, everything is being met. But here the neurological assessment is taking a precedence. Look for the pupils, look for the neurological deficits. If there is any worsening of the neurological deficit or there is a appearance of a new neurological deficit, then don't hesitate in discussing with your surgeon to ask for a CT scan. And a small point from my experience, always remember to take out that neck roll when you are getting a upper cervical spine surgeries done. Medicine is an ever-evolving branch. We'll keep on having new recommendations, new guidelines, but there are going to be gray areas. But always remember, when in doubt, follow the principle of primum non nocere, that is, first do no harm. And my surgical colleagues were, quite professional enough to give me feedback on what they did not want from us. And the list goes from a light patient to inadequate muscle relaxation, non-working EPS monitors due to anesthetic interference. They wanted a non-reliance on blood products in expected high blood losses. They wanted us to use a permissive hypotension and tranexamic acid if required. They did not want any large hemodynamic variations at extubation. Also, no IV lines and monitoring leads in the operating fields. No hypoosmolar agents to be used in navigation-guided surgeries. For awake or functional neurosurgeries, they did not want any delay or inadequate transition between awake and asleep phases. And lastly, the most important, tense brain. Nobody wants a tense brain. So in case you encounter it, a small word about how you tackle it. You have a two-pronged approach. You have a checklist, you have interventions. So your checklist should ensure that there is adequate oxygenation, there is no hypercarbia, blood pressure is not too high, the body and neck position are comfortable, there is no excessive flexion. See whether your hyperosmolar regions have gone or not. If there is a CSF drain, see it is open and it is draining. If you're using volatile anesthetics, keep your MAC below 0.5, and if for any reason you're using vasodilators, try and switch it off or switch to some other drug. You have a tight brain, you have a tense brain. What are the interventions? Possible interventions: hyperventilate, keep the PaCO2 above 25. Use mannitol, redose if required, use 3% hypertonic saline, give a head-up tilt, switch to IV anesthesia, deepen your plane of anesthesia with IV. Ask your surgeon to drain the ventricle. About Lasix, yes, there are studies which show that it may potentiate mannitol, but there are no definite evidence. Steroids, yes, they are very helpful in reducing peritumor edema, but the speed of onset you see is in hours. Now, to conclude, the most important thing, do not lose your calm. And do not fret on things that you cannot change. First, your patient profile. You can optimize it, or you can discuss for an alternative procedure with your surgeon. The second is, there's no point in fretting about your available facilities, work around them. And lastly, your surgeon. He might not be your best friend, but he's not your foe. The interest, is yours as much as his. We are both working for the patient benefit. So it's not such a difficult task. It may not be, it may be impossible, difficult. You do not desire it, but attempt it. I think that's about it. Thank you for your patience.
Thank you, Ashu. That was a very comprehensive and interesting talk. I would request you to please stay on there. And in trying to tell us what not to do, you have so beautifully brought us around to what we actually should be doing. So thank you once again for that. And with that, we kind of come to the end of the lectures. We have a quick question-answer session. I would request all the speakers to kindly join Ashu over here so that you can quickly fire your questions. We are already running short of time or have overshot. So just a few important ones. First question, please. I think there was one hand in the posterior fossa surgery, so I would
a quick round of questions, please. Yeah.
Yes, the posterior fossa question, is the gentleman still here? Well, it doesn't seem that he's still around, so there's any other questions for our speakers here?
My question is addressed to Dr. Ashu. What is the current role of thiopenton in preventing an intra-op surge in ICP?
So we've been using thiopentin since long, and the only way, the only time that we are using thiopentin as of now is when you're using a temporary clip. And when the temporary clip time is expected to go higher, the surgeon has a difficult access to the aneurysm. That is where we are using the thiopentin, not as a routine. But there is actually no contraindication to its use. You can use it, and as I said, you have to work around the facilities that are available at your place.
Madam, initially we all give mannitol. What is the role of Q over mannitol because most of the patients who come to the ICU with infection do not subside their ICP in 3 days. That ICP persists. So what is the protocol you follow in your system? Do you shift from mannitol to 3% saline later on, or is there any role of adding mannitol plus 3% saline both in this patient?
Yeah, for this last point, I would say there are currently studies going on because I've come across them, the combined therapy. So is this benefit over a superiority of a single agent? So yes, I do not have an answer yet, maybe in the future. And yes, hypertonic saline is recommended for mannitol refractory intracranial hypertension. So once you see you have achieved the osmolar serum osmolarity of more than 320, your osmolar gap is high, more than 20, there is actually no fun, no use, no sense in using mannitol again. Yes, you can give a try for hypertonic saline. Give a bolus of 150 ml, check your ICP, try and keep a serum sodium of not more than 155, maximum 116, just not more than that. Beyond that, even hypertonic saline won't help.
Yeah. So to conclude the session, I just request the faculties to be here so that we can facilitate them. And may I invite Dr. Pooja to hand over the memento to Dr. Kavita, please? Yeah. Ma'am, Dr. Kavita, please. Thank you for moderating the session. We have been in touch with Dr. Kavita since 2004-05 when I was in AIMS, and it's a real pleasure having you here, ma'am. Best part is not about like giving an excellent anesthesia. She is the one who has promoted the juniors like anything. So blessed to have you in our faculty, ma'am. Thank you very much.
May I just put in a word? I just want to thank the TASCON committee for calling me here today. I was introduced to you all by, again, thank you, Sumit, for this some years ago. I was always a little curious to know about it, did keep track of you all, and I feel privileged to be here as part of your group today. Thank you so much, and I hope to continue a long association. Thank you.
May I invite Dr. Divesh? Dr. Divesh, please. Yeah. Dr. Satkar to hand over the memento, please. Dr. Sindhuja, please. Dr. Sumit, please come. Yeah, please come to the center. Center. Dr. Keshav, Dr. Priyanka from Stephens, please. Yeah, to hand over. Dr. Siva, I invite you to hand over the memento to Dr. Arnab Das, please. Dr. Sandeep Chopra to hand over the memento to Dr. Ankush Arora, please. Dr. Mukesh Avani to hand over the memento to Dr. Nidhi Gupta, please. Dr. Sunil Gupta, Dr. Sunil to hand over the memento to Dr. Ashu, please. Please. So with this, we come to an end of a very brainy session, and thank you all the faculties. Thank you.